this part where you see the balloon. And can we go through the runs, please?
Yes, sir.
So we started off from no, इससे पहले वाले run से. Yeah, that's the one. So we started off like this and realized that there's hardly any recanalization, so it's mostly chronic. Next run, please. Though the swelling has come down. Next run, please. Next. Even deep inside, there is not much. Next run, please. Okay. Next. So with some difficulty, we could get a wire across. So we had some difficulty getting a wire across. I'll just okay. Hold the wire there. Okay. Do it. Do it.
Yes, sir. It seems it was taking some time to cross the lesion.
Yeah, but once we were in the right track, it went pretty neatly. The only minus point is that our catheter wasn't going at all. So we just took a 10-foot balloon. Next one, please. Next one, please. So finally, a wire or across.
Yes, sir.
आप पीछे वाले रन्स में चले गए, ये तो परसों वाले रन्स हैं, आज वाले आप 24th का नहीं, आज के रन दिखाइए. नेक्स्ट, हाँ ये वाला. We got a balloon in. Next one, please. Yeah, so we inflated this. Next one. Okay. So next one, please. इसमें कितना फ्रेम रेट रखा आपने? And the fluoro off. Sir, off. Sir. क्यों? आपका युद्धवीर आपको
Satwik sir, good morning.
Good morning. Good morning.
So we are taking in the balloon, sir. Again,
we are taking a 10-4. 10-4 wasn't crossing this. Catheter wasn't crossing, but fortunately our 540 balloon crossed.
Yes,
so
sir.
now even our 10 has gone through very smoothly. So we're still working on a termo. The aim is let's balloon dilate the whole track. Okay,
yes,
that's
sir.
where so practically at 1, 2, 3, 4, 5. Between 4 and 5 the region is. There's no waste scheme here except for the proximal part. So I think we have a pressure of 10 now. So for a 10 mm balloon, that's huge.
Yes, sir.
Usually 10 mm balloons, you need a pressure of around 6 or 8. You're going to hold that for 30
pressure
seconds.
Now, sir?
10.
10.
Okay, off. So we're going to just do 30 second inflation here, since most of it is in the normal part. Probably my next one will be more in the diseased part, so will be longer. Okay.
Yes, sir.
Yeah, I think that's an area where
yes, sir.
Yeah, you can see that waste coming up. So that's your SVC in left innominate junction.
That's
you can
pretty
appreciate tight. That's pretty tight. So सेव किया था? Okay, we'll just hold on for a sec. Patient not having pain, but you can see that the waist is still there. And we are at a pressure of, in fact, 11.
Yes, sir.
So you can imagine that at a pressure of 11, there is
That's
still
a
a
pretty
waist.
tight one.
That's a pretty tight one, absolutely. And mind you, no fistulas, no cannulation, so it's just DVT. She's APLA positive now. All the investigations that we did recently, she has come out to be APLA positive. Yes, sir. Do you have an atlas?
Thrombotics.
There though. Okay. So I'm going to redilate in this area. Okay. I'm going to try different sites for the balloon, which one opens it best.
Sir, are you going to upgrade the balloon size, sir, at this site, for this site?
The main problem is pen is not opening, then the problem is the waste is not going.
Yes,
so I don't expect it to go with 14 eyes unless you use a non-compliant balloon.
Ajay, your voice or the Ganesh voice is very low actually. It is not clearly audible. I don't know whether to me only or to all the participants.
Okay. I'm not sure if somebody else can also check if our voice is clear on the lower side.
Sir, is
I can hear your voice, Ajay.
Yeah, perfect.
Right.
yeah,
I think I think the waist has opened up a bit. I think it is opening up a bit.
yes.
That's good.
Yeah, it's opening, sir. Slowly.
It's opening now. It's better. Okay. I'll change the position. I'm just changing the position of the balloon to get our maximum pressure at that area.
At the center, sir?
No, probably one of the edges actually. The proximate. Yes, sir. Just seeing if something opens up. It has opened up. There's no doubt. It
Yes,
was
sir.
much worse. Okay, offset. I think I'll come proximal now. I think one more and then we think of a different strategy. We can make it a cutting one, a scoring balloon. We'll need to upgrade the sheath for that. Let's see. Okay, one more. Sir.
So we have a good number of participants, sir. 24 early in the morning.
24 participants, sir. Very nice. I'm glad that. So we have nearly opened it. So I'm going to keep this for a minute. So 1 minute timer, please.
But Ajay, it is very, very tight stenosis.
Absolutely, sir. And the only thing is, now what? Okay, we have balloon dilated the whole track and maybe some residual stenosis, maybe 20% something here. Do we put in a stent afterwards? Or should we just let it be for the moment?
And Ajay, this is after we have given the thrombosis 48 hours. Definitely, this lesion will need some hardware there.
So the only thing is she's APLA positive. She's got permanent DVT on both the sides. She's a chronic DVT, probably tubercular also, Cox also at some stage. But the only thing is, but the problem is, sir,
now it is not going to stay anyhow.
Sir, upper limb veins, as it is, have a much lower flow as compared to lower limbs.
That's right.
And she doesn't have a fistula to keep the stent patent. So the only thing is, such a long stent, you end up putting probably a 100 plus something, 120 centimeter long stent without a fistula's flow to keep it open.
And also, symptoms have been relieved.
Symptoms have been relieved. She's APLA positive, so she's highly prothrombotic. Will that stent last? And if that stent's got occluded, will we be able to come back and do this again?
I don't think so. You are right that stent is not going to be last, but the lesion which you are going to open, it is also not going to be last without stent.
So, that's something that I think we'll have to take it. Same. So I think Dr. Bedi is also having a similar opinion as mine, that the stent might give us a good radiographic picture on the table today, but
Yeah.
may not solve her problem in the long term.
Yes, you are right. You are right.
Yes.
Patient is already relieved of.
The patient is relieved of her symptoms. Lateral दिखाएं, please. Lateral दिखाएं. So the aim is, or lateral दिखाएं. Yeah.
As she has also inflow issues, so the stent may not be patent for so long, and it might get
Absolutely, we'll have-
occluded, and it can lead to worsening of the symptoms.
आप ये वाली जो लेफ्ट वाली पिक्चर है यहाँ
So
तक
maybe
दिखाएं.
after balloon dilating, we have opened some tracks so that at least there would be some
This
collaterals
is
which
your
can
first
drain.
angioplasty, no? This is
ये
your
वाला
first.
रन दिखाओ.
Yes, sir. Yes.
ये वाला
This
रन
is the
दिखाओ.
first angioplasty.
Suppose this patient comes after
हाँ,
a
इसके
month
ऊपर वाला.
or with the same occlusion.
ये-
Then what is the choice with that?
और पहले वाला. से पहले वाला बेटा.
Or maybe we
और
try
ऊपर.
to
हाँ.
reopen
Now,
again.
sir, now this is the inflow. So that's practically in the axilla. So would you want a stent coming right from the heart till the axilla? Okay.
No.
Off.
Also not going to serve the problem. Yes.
Absolutely, sir. So I think stent is not the answer for her. So we've given her the best option that she has is a good balloon angioplasty and a really aggressive anticoagulation. Now, I think this is a question I would ask Dr. Ganesh here. What anticoagulation would you prescribe? She's APLA positive.
So we'll put him on vitamin K antagonist.
Why not DOACs?
So there haven't been any studies which have been suggesting that, but for the APLAs, they are told that vitamin K antagonists, there are studies which are compared with LMW. For DOACs,
Actually, for APLA syndrome specifically, the studies have very clearly corroborated the vitamin K antagonists, the warfarin or the acetylcholine work better and have less chances of rethrombosis as compared to DOACs. I think the recommendation now is if you have APLA positive, you should continue with warfarin or
No indication for
in APLA. There's no, Dr. Bedi is also saying no indication of DOACs in APLA syndrome.
Yes.
Okay.
Yeah, I
But
would agree,
this-
Ajay. I mean, the only two indications where DOACs don't seem to work are cancer patients and APLA.
Yeah, but I think Amrish, for cancer patient, there's still an evidence which is coming for rivaroxaban as
there
well
have
as
been
apixaban.
studies like
But-
Select D trial is there, sir.
Yeah, I
Which
know, but ACCP still adheres to LMWH.
Yes, sir. Yes.
Right. They
Yes,
haven't changed, but the recent trials have shown improvement.
Yeah.
Yes.
But for APLA, it is a very clear indication. The patient is having very pain here. So that's all chronic.
And Dr. Harita also says that reintervention in the stent will be difficult.
Absolutely.
So the patient comes with these symptoms on the first setting. Obviously, we should settle with balloon angioplasty.
Keeping it traction.
Patient symptoms are resolved.
So I think contrast, full and saline 20 ml.
But she will need an aggressive anticoagulation in future and close follow-up.
Full करके देना. Yeah, absolutely. I agree with you, Ganesh. So I think we had reached our limit of where the normal started. I think I'm going to withdraw the balloon once we are done with our 1 minute inflation and take a contrast run.
Yes.
The only problem is how aggressive do we want to be, and with no fistula to sort of keep that flow patent.
Sir, there is a question from Dr. Kishore. He's asking,
Right.
is there any role of DEB regulatory?
DEB in this, the patient is not having any neointimal hyperplasia, it's all thrombus. So how will DEB help in thrombosed wing of I'm holding sheet.
Maybe if the patient had stent and it was instant stenosis, then it could have helped.
Actually, it is still not. I don't believe it would be an instant stenosis. I would still believe it would be a thrombotic lining which will come up. Central दिखाएं. सारे एक में करें. Yeah. बस ठीक है.
Sir, and do we have bigger diameter DEBs
No, we don't.
Question.
Heparin दिया? Heparin. Saline.
And sir, oral DOACs and NOACs have also no role in atrial fibrillation patients.
Sorry?
In atrial fibrillation also DOACs are not indicated, so NOACs and DOACs. Yeah.
I'm not sure if what are the latest trials, but the trials I last saw, there was some indication in non-valvular atrial fibrillation, where there's less chances of thrombosis. And that's not too bad, actually, sir. Not too bad.
Yes, sir.
I think we got an excellent opening of the vein till practically nominate.
Yes, sir.
But as you can see, there is a lot of thrombus. I think let's keep her on
It is chronic
heparin.
thrombosis, right?
Heparin. I think we'll keep the sheath in
Yes, sir.
and keep her on heparin through this for another 24 hours. Anything else, Ganesh, would you want to suggest, sir?
We have tried opening with a 1040 balloon, sir.
Yeah,
But
we did.
it has opened a bit. But again, ballooning it with a higher balloon, I guess there won't be any.
No, there is no space putting the higher balloon.
Won't be any benefit. So at least we have opened up some collaterals. Some collaterals will drain the.
Absolutely, I think absolutely
it should suffice, maybe, sir. Oh.
Yeah, absolutely, I agree.
So we want to keep sheath, sir. Should we keep the sheath, sir?
We're keeping the sheet for heparin infusion. So whatever thrombus that we have opened up, I think we're going to keep a slightly higher flow.
Yes.
And maybe go for 4 ml per hour or something, so that the whole sheath is well flushed with heparin. We're just doing a balloon angioplasty. Maybe just keep it patent for a day, and then hopefully the low molecular heparin would take over.
Yes.
Right?
Any questions from the audience?
125 to shoot. 70. Very good. ये दो चाहिए मुझे. मैं ये दो लूँगा.
Will you put this patient on antiplatelet also?
Pardon, sir?
Will you put this patient on antiplatelet also?
Yes, sir. Basic aspirin would definitely be given, sir. 14 की sheet. So we're just getting ready for the next case, sir.
Yeah.
So 5 minutes she'll be wheeled out.
As we take on the next case, I would request Satwik, sir, are you ready with the presentation, sir? Hello?
Yes, I
Hi,
am.
Hi.
I'll stop my sharing, sir, and I'll enable you to share.
Yeah. So I'm just going to should I share?
Yeah.
Yes, sir. I've done it.
So I'm logging off now.
Yes, sir.
Thank you, sir. Thank you, sir.
Thank you.
Yeah.
Asha. 0.023.
Sir, can you start your video,
38
sir?
minutes.
Yeah. Can you see my screen now?
Yes, we can see your screen, sir, but we can't see you, sir.
You want me to start my video? Okay, sorry.
I'll spotlight it, sir.
Can you see me now?
Yes, sir. Yes, sir. I can.
Can you also see my screen?
Yes, sir. Yes, sir.
Hi, Satwik.
Sir, good morning.
Good morning.
This is going to be a brief kind of tutorial on uterine artery embolization. I know we had a similar kind of tutorial by Dr. Virendra Shiroin on prostatic artery embolization. And we do a fair bit of these embolization procedures. So I just thought I'll show you how this is done and a brief overview of the indications and the outcomes. So obviously, this is an immensely distressing condition for women who might present to a lot of gynecologists with dysmenorrhea, with metrorrhagia, with cesarean scar pregnancy, with all kinds of uterine arteriovenous malformations, and sometimes with very large fibroids, and they are young women who do not wish to subject themselves to surgery, wish to preserve fertility, and so on, and therefore tend to opt for minimally invasive techniques for uterine artery embolization. So this is, if you peruse this paper that I've presented as a slide, this is the first record that was published in the Lancet in 1995 of a series of uterine artery embolizations for the purpose of seeking some kind of an intervention for symptomatic uterine fibroids. Okay, and the last name, this is Jean-Jacques Malan, who's a French radiologist, who collaborated with Ravina, who's a gynecologist, and they did their first uterine embolization procedure in 1974. Now, if you remember my presentation from day before yesterday, that was also the year that the first balloon angioplasty, peripheral balloon angioplasty, was done in the iliac and the femoral veins. So this has a fairly distinguished history going back to the last century. 1974 was the first procedure done, but they were able to collate data in 16 patients. Again, there is this problem of gynecologists not referring patients to interventionists for such procedures. So this was published in 1995, was submitted for publication in 1994. So it took almost 20 years for these people to collate data of 16 patients between the ages of 34 to 48 and present data of uterine artery embolization for symptomatic uterine fibroids. But the first procedure for this was done way back in 1974. This is a brief schematic representation, pictorial representation of the anatomy of the uterine arteries. And what happens is that the common iliac artery, as it descends on the pelvic floor, roughly in the fourth and the fifth lumbar vertebra, it bifurcates into the external iliac and the internal iliac. Okay. Now you have to do some imagining inside your head. This is the internal iliac. Okay. It used to be called the hypogastric artery earlier on. So let's say the common iliac is coming from, divides into the internal iliac, and the internal iliac subsequently divides to the anterior division and the posterior division. Okay. Now the posterior division largely passes through the greater site. Then most of them are visceral arteries that tend to pass through the pelvic floor. And this is the region of the broad ligament of the uterus. This region is the area of the broad ligament of the uterus. So what happens is that as the internal iliac artery, the anterior division of the internal iliac artery comes down, it tends to give off the uterine artery in the broad ligament. Okay, this is the round ligament here. This is the broad ligament, and somewhere along the lower part of the broad ligament of the uterus, from the anterior division of the internal iliac artery, it's a uterine artery. Okay, and as you'll notice, what tends to happen is that as it comes closer to the surface of the uterus, there is an ascending branch which goes up, which travels up along the lateral margin of the uterus, and there is a descending branch which goes anterolaterally on the wall of the uterus, further down onto the cervix and the vaginal surface. Apart from that, as the ascending branch comes down, it gives off further vaginal and cervical arteries. But as you'll also notice that the uterine artery also gives off branches to the cervix, and the descending branch also gives branches to the vagina. We are largely concerned with the ascending branch of the uterine artery. So just to recapitulate, somewhere here will be the internal iliac, which will give an anterior division and a posterior division. Posterior division will largely give your gluteal vessels and so on, and also the rectal vessels. And the anterior division will give the uterine, the inferior vesicle, the vaginal, the cervical branches, and so on. So we are concerned with the uterine artery, which travels in the lower aspect of the broad ligament, comes close to the surface of the uterus, and virtually on the surface of the uterus gives off an ascending branch and a descending branch. Okay? Now, this ascending branch will further give these branches on the surface, on both sides. You can see the anterior surface of the uterus, but there's also a posterior surface of the uterus. And these branches are called arcuate branches of the uterine artery. Arcuate, the word comes from bow, like tir kaman. So because they form a sort of bow over the surface of the uterus, they're called the arcuate branches. And then from these arcuate branches, perpendicular into the substance of the myometrium all the way to the endometrium, are the spiral branches that supply the meat of the uterus. So again, the ascending branch goes up, it turns, and then gives off branches to the fundus and fallopian tubes, and then to the ovary. It's here that it forms an anastomosis with the ovarian branch of the aorta. This is a separate artery altogether. It is coming from the other side, the ovarian artery. It also gives off branches to the tube, as you can see. You see my cursor, right? Ganesh, can you see my cursor on the screen?
Yes, sir. We can see the cursor.
So this is the ovarian artery, which comes from the other side. This is a branch of the aorta. And this is our uterine artery, which is giving off the branches to the fallopian tubes and ovarian branches. And together they form a sort of anastomosis in the ovary. Now, the reason you have to remember all of this is because when you're doing an embolization procedure, the first principle of medical ethics is to be followed, which is primum non nocere, first do no harm, okay? And what that means is that when you're injecting embolic particles, which are meant to occlude physically some arteries in the body, you must make sure that these particles don't travel to other areas of circulation and affect other parts of the body inadvertently. So as you are going to inject embolic particles into the uterines, you have to concentrate on these vessels predominantly, okay? On the arcuates and the spiral vessels. In case of cesarean scar pregnancy, the spiral vessels will supply the placenta. So you have to concentrate basically on these vessels. You have to try and leave as much as possible the cervical and the vaginal supply. But even if you do manage to enter these, you have a very significant blood supply and vascularity coming from separate vaginal arteries and cervical arteries. So you will not get a lot of damage. But if you enter the ovarian anastomosis, that's when you're likely to damage the ovaries and lead to infertility in a certain fraction of the patients. That is not permitted. Okay, so you have to be very careful to try and not try and make sure that your embolic material does not enter the ovarian anastomosis in any circumstance. I hope that is clear. So we move on to the indications for uterine uterine artery embolization. And as I said, that when you are specifically getting into the branches of the uterine artery, this procedure becomes a super selective embolization procedure. Okay, so it's super selective uterine artery embolization. The indications, obviously, you have large uterine fibroids, which are symptomatic, which might be contributing to pain, sometimes increased bleeding during menses or otherwise. And this is a woman who is young, perhaps doesn't want to, for whatever reason, subject herself to a surgical procedure. If there are more than one fibroids, which would make the surgical procedure difficult, all of those become candidates for uterine fibroids for embolization. Acquired uterine AV malformations. These usually are a consequence of traumatic abortions, of medical and surgical abortions, which sometimes open up some strange communications between the arterial system and the venous system in the substance of the uterus. Starts off from the endometrium, then starts spreading into the myometrium, and they become full-blown AV malformations. Sometimes you also have to be wary that these malformations could be found in gestational trophoblastic tumors. So it's not just acquired on account of a botched up abortion. It could also be on account of a gestational trophoblastic tumor. Cesarean scar pregnancy. This is when the sac burrows into a previous cesarean section scar. And because it is burrowed into that, there's a possibility of dehiscence, there's a possibility of severe bleeding, and therefore, in these cases, uterine artery embolization, superselective embolization is also indicated. And usually it's combined with some amount of methotrexate therapy, or sometimes even injection of potassium chloride directly into the fetus, usually into the beating heart of the fetus, which is done on ultrasound guidance. Also, incomplete abortions with extremely vascular retained products of conception. Okay, so these are cases when there are RPOCs still in the uterus, and any attempt of actually evacuating these RPOCs might lead to torrential hemorrhage. And therefore, these patients are usually first subjected to superselective uterine artery embolization, and then a kind of evacuation, suction, or whatever, curettage by the gynecologist. Adenomyosis is the other indication. Cervical neoplasia with bleeding. Sometimes they're fungating, macerating lesions in the cervix, which are bleeding, which don't respond to anything else. And primarily to staunch bleeding, and as palliative, you might have to perform an embolization procedure. And of course, as is quite common and unpredictable, severe torrential postpartum hemorrhage. Usually these patients, a large majority of them present to us and are referred by gynecologists, but also now that awareness is increasing, these are patients who have persistent recalcitrant bleeding, sometimes torrential hemorrhage that might need multiple blood transfusions. And when you find one of these conditions in the uterus, that you might be required and might be called upon to perform these procedures. So what's the hardware that you require for this? First of all, it's a procedure done under local anesthesia. You need a 5 French sheath. You need what's known as a Roberts uterine catheter. You need your standard workhorse guide wire, which is the Terumo 035. You might require a microcatheter. And obviously, you will need embolic material. You could opt for PVA particles or embospheres or gel foam, and sometimes you might require glue embolization. So you require NBCA in those cases, which is N-butyl cyanoacrylate glue, along with Lipiodol to visualize where your glue is going. And I'll show you instances of each of them. This is what a Roberts uterine catheter looks like. So this is prefabricated with this bend here, you can see, okay? And the catheter retains the memory of the bend. So even if you were to straighten it and remove the wire, if it has space to bend, it will form this configuration. And the other bend is this. This is in the tip of the catheter. This is a Cook catheter, which is, you can see the hydrophilic tip, the black colored hydrophilic tip. Unfortunately, these catheters are no longer available, manufactured by Cook. You do have a similar variant, the RUC, the Roberts uterine catheter, manufactured by Merit, which is available, but it does not have the hydrophilic tip. Unfortunately, I'm not carrying a photograph of the Merrick catheter. It looks more or less like this, but I'd say it's clumsier and slightly more unwieldy than the Cook catheter, which used to be my favorite, but unfortunately, it's not available anymore. So let's show you what uterine artery embolization for fibroids would look like. And this is a standard puncture technique. You can see the video, you've seen many of these, you're doing all of this, but just because this was part of a presentation at a different forum, I'm just going to show you what an ultrasound guided puncture looks like. The reason we're doing an ultrasound guided puncture is because you want to be absolutely sure that you're not damaging the intima, because here, the amount of heparin that you administer is nearly 500 units. So if you're botching up your puncture and raising a flap, causing a dissection, it's possible that it might lead to thrombosis, and you're giving very little heparin. So you might have to then open up. Also, you don't want to do a posterior puncture because then you might end up with a pseudoaneurysm. So all punctures to be ultrasound guided. This is what a standard aortogram looks like. And you can see this area is showing a blush. Okay, I'll play this again. You concentrate on this area. This is showing a blush. And that's where you have to concentrate on. Now, also, if you notice that this is a young, healthy woman, and usually these patients tend to have a fairly sharp bifurcation, acute bifurcation of the abdominal aorta. And you might require this little improvisation in your catheter, which is a pigtail catheter, which has been snipped off, as you can see here, to give us what is known as a snipped pigtail catheter, which we place on the aortic crotch to cross over to the other side, because you might not be able to cross very acute bifurcations with the Roberts catheter. Okay, so this is how the bifurcation is crossed. This is the snipped pigtail catheter, and we are on the other side. Okay, now as I had said that the internal would take off somewhere between the L4 L5 level. Okay, but now you've managed to enter the but it might obviously differ in various patients. You've now entered the internal catheter. The external will obviously go straight down. The internal artery, internal iliac artery, the external would go straight down. And when you've managed to get your wire in, this obviously, once you've crossed onto the other side, you start using the Roberts uterine catheter. And this, so you can see this is the posterior division, which is supplying the gluteals and the other vessels. And this is the anterior division. This is what you must concentrate on. Okay. And you can see this vessel coming off. Is that visible on the screen, Ganesh?
Yes, sir, it's visible, sir.
Yes, sir. Yes, sir. It is.
So
We
this
can
is the
see.
anterior division, and this is the uterine artery, which is usually taking off. You will see the blush here soon.
Yes, sir.
That's what you must focus on. Okay, this is the uterine artery has been marked. Okay, and so now that you've managed to cannulate, as you can see, so this is very clear. You know, you're practically on the surface. The descending branch usually takes off somewhere here. Okay, this does not have a very predominant descending branch, or possibly it is this one, which is going down because it's not producing a lot of visualization of the cervix and the vagina. You're quite safe. Okay, and you can see these are the arcuate branches. Can you see those arcuate branches? And towards the very end, you have these spiral branches. Can you see that? These will be the spiral branches. These are the arcuate branches. So this is what you must concentrate on. Okay. And this is the injection of PVA particles, which we introduce. Usually, if you have to penetrate for different reasons, you might be required to use different sizes of PVA particles. If you're dealing with a fibroid, it will usually be up to 300 microns. If it's bigger than that, if you're targeting a slightly bigger vessel, it'll be between 300 to 500. If you're targeting a slightly bigger vessel than that, then possibly a size much more than that. And you see that the circulation is sluggish. Now, okay,
Yes, sir.
yeah, you can see that.
Yes, sir.
And this is the, okay. And now you can see that
Yeah.
fibroid is no longer visualized, okay. So,
Right.
so this is pre, you can see the outline of the fibroid from this side. This is post-embolization where you cannot see the fibroid, okay. And yeah, now we're withdrawing. So the idea is that this maneuver is going to be used for cannulating the ipsilateral internal iliac and the uterine artery. So I'm just going to show you that. I'm just going to run through the film again. You basically withdraw out of the internal iliac and cannulate the external iliac again. Once you've done that, you take the tip of your catheter all the way to the head of femur. Okay? That's how it's been taken to the head of femur. You withdraw your wire till just, so when you actually reach the head of femur, bang on the crotch of the aorta, you'll find a radio-opaque marker. It's not very clearly visualized in this angiogram, but believe me, there is a radio-opaque marker here. That tells you the location of the pre-configurated bend, okay? And what you have to do is now take your wire just behind the radio-opaque marker, and then the direction of the torque should be towards the aorta. You must push the catheter up. What will happen is that the entire catheter will fold upon itself and start moving into the aorta, okay? And I'll show you how. Do you see that? Yeah. So now you keep pushing till the tip of the uterine catheter now points towards the ipsilateral iliac. Cannulate the ipsilateral iliac. I'll show this again. Keep pushing up till the tip points towards the ipsilateral iliac. Cannulate the ipsilateral iliac. And then turn your catheter and cannulate the ipsilateral internal iliac. Now you're inside the internal iliac, okay? So now as you are trying to cannulate the common iliac, I'll play this again, you have to pull the catheter out, okay? So now the catheter is being pulled out and you have cannulated the common iliac and subsequently the internal iliac. Okay, that's another view of the same thing. And this is an angiogram to confirm that you have managed to enter the internal iliac, but also this is obviously moved beyond the internal into the anterior division and the uterine, and in fact, well beyond the descending branch of the uterine. And you can see now you're only in the area which is supplying the uterine fibroid. Can you appreciate the fibroid here?
Yes, sir.
Yeah,
We
so,
can see the spherical. Yeah.
so this is the fibroid that you need to deal with. As you had seen,
Yes, sir.
you managed to knock off the blood supply from this side earlier, and now you've managed to enter the fibroid supply from the ipsilateral side. Okay, I'll just play the film again. And that's...
Yeah, it's very well visualized. Yeah.
So now you've got embolic particles being injected. Can you see the fibroid lighting up? Yeah, those are the embolic particles that are being injected into the uterine fibroid from the ipsilateral ascending branch of the uterine artery. And once you've managed to inject the PVA particles, if you still want to pack up something further into the arteries, this is the gel foam technique that we perform in our department. And this is basically a standard issue gel foam, which we pulverize into a kind of powder. And then this is the bottle of the PVA particles, and we're done with the injection of the PVA particles. This we're pulverizing into a kind of powder and then adding contrast into it and then injecting this. I'll show you how this works. Can you see that? It's shaved off using a scalpel. Yeah. So it's been shaved off, and now these pulverized particles will be pushed into a syringe. And then along with contrast, you use the kind of tesserae technique that you use for sclerotherapy, but not air. You're using contrast on the other side. You attach a three-way stopcock, and then you make that into a gelatinous kind of paste or jelly, which then you will use for the sake of embolization. Okay? That's how you get that gelatinous mix along with the contrast agent. This is a fairly effective embolic. This is fairly effective embolic material, but it's short-lasting. Okay, PVA particles are for life. Embospheres, which are acrylic particles, are also for life. This is short-acting. So if you wish to embolize a slightly bigger vessel, or if you wish to embolize pre-operatively, you can use this technique. I just thought I'll demonstrate. But anyway, so this is these are the embolic particles being injected again, as you've seen. And now you will notice that the fibroid is no longer seen. Okay, so that's a successful embolization procedure for the uterine fibroid. You can see this is pre-embolization and this is post-embolization. Very effective, and you can see that you cannot. You're far beyond. You've made sure that you haven't gone into the branches that take off to the ovarian come off from here. You've gone further ahead so that you don't disturb the ovarians. And this is how you then subsequently retrieve the catheter. You push it back into the aorta, okay? And you turn it around and then cannulate the contralateral side. You start pulling back on the catheter. You've managed to get into the contralateral side. Okay, that's how you've gone into the contralateral side. You're pulling the catheter, remember, you're pulling the catheter out of the sheath. You've gone to the contralateral side, and now you just need to pull it out because you've achieved that pre-configured bend. Okay? That's the catheter being pulled out. Okay, so now for cesarean scar pregnancy, similar technique, but as I said, you have to go specifically into what seems to be the sac. Okay, that needs to be targeted. You need to be sure that you're in the right place. Again, PVA particles being injected. Okay, you can see that the ovarian branches have been spared. The ovarian branches, anastomosis would have been seen somewhere here. You can't visualize that. That means you're safe. And that's post-embolization. You can no longer see the scar pregnancy. Okay. For AV malformation, this is a tricky one because this is where you have a high flow communication. You can see that the venous system is filling up right away. This is the artery, and you can see the vein filling up right away. Can you see that?
Yes, sir.
Yes. So yeah. So this is a high flow acquired AV malformation. Okay. The venous system filling up again.
Yeah, it's good.
Here you'll have to go and use. So now we've managed to come into the nidus. Okay, this is we require a micro catheter which is coaxial, which is being taken through, and we now inject NBCA glue with lipidol. This is about, I'd say, 50-50 concentration. This is the uterine, Robert's uterine. Coaxially through the RUC, a micro catheter has been taken, and through that we're injecting NBCA glue along with lipidol. The reason to inject this is because this glue will polymerize immediately on the arterial side of the AV malformation. Okay, what happens is that if you dilute this further, let's say instead of 50-50, you would take about 30 glue and 70 lipidol. Then, because lipidol is what decreases the viscosity of the glue, this is likely to travel further and enter the venous side of the circulation. Sometimes it might even embolize to the pulmonary arteries. So you have to be very careful while you're injecting NBCA glue so that it stops in its tracks on the arterial side of the nidus of the AV malformation. Okay, this is what has been achieved. You can see this again. And then you have to be careful that the polymerized glue doesn't stick to the catheter. So you have to yank out the catheter as soon as you stop injecting, because otherwise the catheter might get stuck to the polymerized glue. Okay, so slightly tricky, but usually is very successful in these matters. As you could see that after that vessel was embolized, there was another vessel which was giving off supply to the AV malformation that also needs to be embolized. So you have to be sure that AV malformations usually, tend to pull supply from various sources, sometimes even from the inferior mesenteric artery. Okay, so you have to be very careful about this and cannulate every conceivable vessel to see if there's any supply coming off. In this case, it's coming off from another branch, and that needs to be embolized as well. That is happening. That's the glue coming out and embolizing this vessel, which was also contributing. Again, you can see that it's in the arterial side of circulation. It's not going on to the venous side. And you can see that there is absolutely no venous drainage now seen. The AV malformation has been quite successfully. The vessel remains patent and consistent. So that's more or less super selective uterine embolization. I'm happy to take questions if there are any.
Sir, there are questions in the chat box, sir.
Okay, let me.
So, yeah,
sharing.
Dr. Pranay is asking, how do you manage the post-embolization pain and what's your protocol regarding hospital discharge?
Hold on. How do you manage post-embolization pain and yeah, right. So that's an excellent question, because a lot of these patients are going to have very severe pain, which is in the pelvis and lower back. And what a lot of people tend to do is that, first of all, you have to prime the patient about what to expect, because what happens is that you tell them that it's a minimally invasive procedure. There'll be a small puncture in the groin, and we'll be doing this entirely from a needle prick. But they're not concerned about any of that. What tends to happen is, as you're knocking off more and more blood vessels of the uterus, there's a pain of uterine infarction, which is quite severe. So first of all, it starts with priming the patient about what to expect and where to expect it. If you do that, in my experience, they're prepared and it hits them not to that an extent. A lot of people tend to electively do this under spinal or epidural anesthesia. But the trouble with that is you can't have an epidural catheter and then it'll have to be, the removal will have to be delayed because you are giving a small amount of heparin. So sometimes that could be a concern. But I think most of these patients do respond to a combination of a non-steroidal anti-inflammatory agent along with a mild antispasmodic. Sometimes you might have to give tramadol, but in a fraction, I do agree that it might pain quite severely, and sometimes we might have to involve the pain clinic to administer IV PCA, patient-controlled analgesia.
All right, sir. So there is one more question, sir.
Discharge is usually on the next day. If there isn't any significant pain, usually I think the pain lasts through the night. I mean, most of our patients, by the time they're up and about in the next morning, are completely pain-free. Very rarely would you say that it lasts more than 12 to 16 hours. Usually it starts almost immediately as you've started to embolize the other side. That's when it hits. Usually it stays for about 6 to 8 hours, but never usually more. If you start knocking off a lot of blood vessels, then obviously it'll be quite severe. But if you manage to be super selective, it usually stays not 6 to 8 hours, but almost never more than 12 hours.
Yeah, right. So Dr. Swadesh Sarkar is asking, are there any contraindications for uterine artery embolization?
So yeah, well, contraindications, you have to make the patient aware that you are going to be exposing the patient's pelvis and particularly the ovaries to some kind of radiation. Okay, and be very careful not to get into the ovarian anastomosis as I had explained, but sometimes it's impossible to escape it, particularly because the branches are arranged in such a way that it's not possible to avoid the ovarian branches. Let's say there's a fundal fibroid in the fundus. So that is difficult to treat. Sometimes you might have some reflux into the ovarian branches. So you have to advise these patients that there is roughly about a 15 to 17% decrease or loss in fertility, 15 to 17% chance of decreased fertility following the procedure.
Right, sir.
Apart from that, there isn't any major problem. What I would like to point out, mention during the process of publishing this, and I have found some references in international literature also, that when you're doing this for fibroids, very large fibroids particularly, I would say in 1/5 of our patients, about 20% patients, in about 4 to 5 months, sometimes even in 3 months, the fibroid, which has been infarcted, kind of enucleates and is virtually delivered vaginally, almost spontaneously. It is followed by a recurrence of pain in the lower abdomen, and you'll find that a very neat and usually preceded by some amount of foul-smelling discharge, and then this very neatly kind of delivers itself out, and the patient is immediately relieved of the pain. So about 3 months to 4 months post-procedure, there is a recurrence of pain, lower abdominal, followed by some amount of foul-smelling discharge in about 1/5 of our patients, 20% patients, which have been treated for fibroids, particularly large solitary fibroids. And then it kind of spontaneously enucleates and disengages itself and delivers spontaneously. Apart from that, no real contraindications for uterine artery embolization. You know, you have to be careful in cases of acquired AV malformations about the blood supply. You shouldn't be, if you're going through the IMA, if there are branches that might share supply with the rectum, you have to be careful there. So, I mean, these will have to be technical specifications, but apart from that, I don't think there are any great contraindications to uterine artery embolization. I can see a question about the role in ectopic pregnancy and ovarian torsion. No, there isn't. There isn't. That has to be.
Satwik, there is a small query which I have. As we were talking day before yesterday, when the Virender, they presented the prostatic artery embolization,
right?
Way uterine artery embolization.
Right.
Why these programs and these procedures are not taking off that way as it should be? And especially see the patients of the uterine fibroid, they are rampant, and so many patients, the gynecologists, most of the patients, they are benefited by uterine artery embolization in the case of the uterine fibroid. See, leave the AV malformation, leave the postpartum hemorrhage, and there, so they are in the fix. So they have to send the patient, and we are doing it. But why not that much number of the patient of the uterine artery, this uterine fibroid patient, they come?
Yeah, I mean, my sense is that because I don't think we control the supply of these patients. I mean, in the sense that these patients will primarily present to gynecologists.
So gynecologists are not convinced by this procedure,
no,
or
that. I mean, it's fundamentally it takes certain amount of integrity for a gynecologist to refuse a surgical procedure and send the patient and refer the patient to a minimally invasive procedure. But also sometimes I would like to make the distinction that as opposed to a prostatic artery embolization, where the indications are quite narrow and the outcomes in a lot of cases are not that well defined or gratifying, uterine artery embolization is an extremely gratifying procedure. We've rarely had failures. Most of the patients, I would say, a vast majority of our patients are extremely happy with this maneuver because it saved them any incision, any surgical procedure for any indication. Patients are exceedingly happy. The bleeding stops, the pain stops. The only trouble with fibroids is that it's a slow path to regression of the fibroid, okay, as opposed to a surgical procedure. If you're doing it for bleeding, for recalcitrant, intractable bleeding, the effect is almost immediate and gratifying. But for fibroids, you have to counsel these patients carefully, because what happens is that it's going to regress very slowly over the next months. And it might take as long as 1.5 years for it to virtually come down to a very small size. The effect in fibroids is not immediate in terms of the size of the fibroid. So if someone's got a large fibroid, which is a space-occupying lesion, some people have almost fibroids the size of an 18 or a 20-week pregnant uterus, which is producing a bulge above the pubic bone, these patients will still have the bulge once they're out of the hospital after the uterine artery embolization. So in that sense, in that subset, if you're looking for immediate resolution of physical signs, it is not going to happen. The bleeding associated with fibroid is going to immediately go away. But the size of the fibroid will take time to regress. So that's where the importance of counseling and letting them know what to expect and what sort of time frame this is going to work on is important.
You are very right. See, for the gynecologist and for the patient, if the family is complete, patient is 35 years plus, she's having a one boy and one girl, the easiest way, go for the hysterectomy. Even the gynecologist say, now your family is complete, and we will remove your fibroid, we will remove your uterus, and the patient also think that it is a one-time procedure, okay. So that is very easy for them, but they are not convinced. You are right that because the regression in the case of the fibroid is very, very slow. Yes.
It mentions, there's a question that I can see, size of uterine arteries, cause of any limitations? Usually not, because for whatever reason, for fibroids or for AV malformations or for vascular retained products, if you have or cesarean scar pregnancy, usually the uterine arteries dilate physiologically to accommodate more blood supply into these pathologies. So it's not really a problem. In fact, if the uterine arteries are tiny, this patient probably does not require uterine artery embolization. There's another question which says, from Dr. Swadesh Sarkar, I think it says, is there need for per-vaginal clot removal in case of AV malformation? Well, usually they tend to kind of come out on their own spontaneously once the bleeding stops. You don't need to physically evacuate clots. There's a question which says, from Harita Kilaru, saying, is there, in case of uterine cancer, if you're doing embolization with temporary agents and surgery for some reason is not done, will tissue recover or worsen? No, so that depends on, again, what level of embolization you've achieved. Usually, when you use temporary agents, you tend to go slightly proximally into the vascular supply. You don't go distally all the way. When you use, when you're doing it for fibroids, you need the embolic particles to permeate into the substance of the fibroid, which is why you need smaller particles, under 300 microns for fibroids. If you're going, if you're coming out, the more proximal the vasculature, you need slightly bigger particles. If you're using temporary agents, that basically for the main uterines, usually doesn't cause a lot of problem. But we usually haven't encountered such a situation if a patient is being planned for surgery and we've been referred the patient for preoperative embolization for whatever reason. I mean, even renal artery embolizations for vascular tumors of the kidney, we usually do it a day before. We have a fairly significant series of doing embolizations for nasopharyngeal angiofibromas, juvenile angiofibromas of the nasopharynx. Again, we referred the patient about 24 hours before the procedure, because if you wait longer, there will be some inflammatory process that will be set into action, and that might make the surgical procedure slightly more difficult. Can fibroids recur? Well, not the ones that have been embolized. It's if there's any kind of predilection in the woman that produces recurrent fibroids, of course, that you cannot treat. But here you're doing a super selective embolization of a particular fibroid, which is not going to recur.
I think now our case is ready in the cath lab, and
Okay.
Satwik, very well done.
Right, sir.
Thank you, sir.
Ganesh, what
Sir, in case of sir AVM,
Yeah.
is uterine artery embolization is the cure, sir, or should we have to monitor that again?
So of course you need to monitor again. So what I tend to do if you find an AV, that's a great question actually. If you find an AV malformation on ultrasound of the pelvis, my advice would be to first get a CT angiogram done. Okay?
Yes, sir.
What happens is that on ultrasound you must also evaluate and measure what's known as the uterine artery resistive index, because in AV malformations the end diastolic velocities will be very high. Okay, so the resistive index would alter quite significantly. So in these patients, I think you must subject them to a CT angiogram.
Right, sir.
It gives you on one image all the branches that are supplying the AV malformation. Let's say there are some branches that are coming from the inferior mesenteric artery. You can then plan your procedure well. And because otherwise there would be no reason for you to cannulate the IMA, to look for branches. But so I think a pre-procedure CT angio for uterine AV malformations is mandatory. And I think if the patient has recurrence of bleeding or on subsequent follow-up ultrasounds has persistence of AV malformation, then you must evaluate this patient further about what you've missed. Usually it doesn't happen. Sometimes.
Yes. Yeah. Thank you, sir.
Okay. Right.
Yeah. Are we? So are we ready at the Gangaram Hospital?
Ganesh, what's about the case? What is going on in the cath lab?
Sir, Ganesh is scrubbed, sir. I'm just asking. Yeah.
Who is sitting on the laptop outside?
I will ask, sir.
Dr. Bedi is also scrubbed?
So we will be just starting the transmission from Gangaram Hospital. They have just exposed the groin, taken control of the femoral artery, and brachial puncture has been also done for the next case. That is a fenestrated EVAR.
Okay. What is the actual plan, Nikhil, in this case?
So, like yesterday we discussed, the patient has right common iliac artery occlusion and dumbbell-shaped aortic aneurysm,
Yeah.
which is involving both the renal arteries and SMA. Yeah.
The
So
celiac is spared.
yeah, celiac is paired, sir.
Celiac is
So,
patent or occluded?
patent.
Okay.
So the plan was to do a scallop or a chimney for SMA and fenestration for both the renal arteries, and we will be converting the device into AUI on table.
Okay.
The
One side
contralateral
iliac is occluded, one side is patent.
yeah, one side is patent.
Okay.
And we will have to preserve the internal iliac also.
Okay.
So we will have to we calculated the required length yesterday, which was around 159 millimeter,
Okay.
and the device length we have is 166, and also we calculated the distance for the fenestrations, distance between the SMA and renal arteries, angle of origin of both the renal arteries. Left renal artery on the CT angio seemed to arise from aneurysm per se compared to right one. Right one is not arising in the dilated portion of the aorta, but left renal artery is arising from fairly dilated, means aneurysmal part of aorta.
Okay.
And as this patient is 77-year-old, we are not planning to do the RCTO and recanalization of right common iliac.
Are we planning to do the immediate post of the FEM-FEM crossover
No,
bypass?
sir. No, it is chronically occluded.
Okay.
And patient already have developed multiple collaterals and he's not symptomatic for his arterial disease. So right now we are not planning for a FEM crossover.
Okay.
So only thing that we have to do the on-table fenestrations, and SMA plan will be decided maybe scallop or chimney.
Okay.
Hello, Ajay sir? Ajay sir, Vedi sir, am I audible there?
Hunter Adams, you've been accused of practicing medicine without a
Hello? Hello? Nikhil? Am I audible?
Yes, you are audible. Yes, Apur.
Sir, Ganesh here, sir.
Ganesh. Yes, yes,
Sir,
Ganesh.
we have taken up the patient, as you can see in the cath lab camera images. So we have taken up the patient, we have given the general anesthesia, and we have opened up the left groin, and we have taken the control of the CFA, and already we have taken the left brachial control and
Yes, we
brachial.
can see on the screen. Yes, you have taken a brachial puncture.
Yes, sir.
Yes.
And also taken a right brachial puncture. Also we are doing now. We'll take sheath, Python sheath we are taking in it. And I will request Dr. Ratuish to share the case details. Okay, sir? Okay, Ratuish, can you share it?
Yes, sir. Thank you, sir. Good morning, everyone. I will just brief everyone about the case right now. So we have a 77-year-old gentleman who has presented with complaints of pain in abdomen, which was radiating to back since 4 days. He is having hypertension, CAD. Is a post PTCA done 3 years back, and is a known case of seizure disorder on treatment. On examination, the right distal pulses are absent. Everything below femoral is absent. Femoral is also absent, and left side, all the distal pulses are palpable, including femoral. Echocardiography is suggestive of 50% of ejection fraction.
And CT angio shows a bilobed abdominal aortic aneurysm, which is 3.8 centimeter at the renal artery level, involving both the renal and SMA, and infrarenal level is 5 centimeter, involving the IMA. And it extends along the right CIA with a periaortic organized thrombus and right CIA occlusion. So the plan is to go for a Fen EVAR with a surgeon modified graft, where we'll be converting to aortouniiliac graft with 3-vessel fenestration via the left CFA open and bilateral brachial artery percutaneous approach with our EVAR guidance software. So I'll get back with Ganesh sir.
Ritwij, do you have any image of CT scan or something?
Yes, sir. I will show you the CT scan image.
Do the screen share if it's there in laptop.
Sir, can you appreciate, sir? I'm showing via the Droid cam.
Yes.
Yes. And multiple areas of calcification along the aorta and bifurcation, and there is right CIA EIA occlusion with reformation at the CFA.
Yeah.
Yeah, we can see that, and someone can make it spotlight if possible. Yeah. So there is a
This is the
aneurysm. Yeah, it is involving both the renal arteries as well as the SMA, as we could see, and the right common iliac is completely occluded. In the part, it is only the calcium which is visible. So we have exposed the left common femoral artery, and we are also planning to do brachial approach, but bilateral brachial approach.
I want extra people out of the room.
There is a CT, 3-dimensional CT outside in console also.
ओके एक सेकंड किसका है ये फोन किसका है घुमाना ऑफिसर का
नहीं this is मेरा फोन करना है ना मेरा फोन आशा के पास है मेरा फोन आशा के पास है कॉल मैंने
आपको अनम्यूट कर दो
ठीक है एनी टाइम मिडिल में किसी को डायरेक्ट करेगा बस ये बाहर ही
एडमिट किया
अरे
राइट वाला ड्राइंग में आएगा लेफ्ट वाला एसएमए में आएगा
बेदी सर सर
हाँ हाँ वही तो डिस्कनेक्ट हो गया
मेरा फोन
अब चलेगा लॉगिन कर दिया उसी को ऊपर दबाना था वीडियो हाँ वीडियो बंद कर दी हेलो
Hi, sir.
आई कांट हियर या ओके
Hello.
थोड़ा सा कम कर देना हाय
Yeah.
हेलो
Hi, sir.
या हाय
Morning, sir. Hi, sir. Yeah.
603
Right now we have, sir, 43 participants, sir.
ओके
Yeah.
थोड़ा वॉल्यूम कम कर दे बहुत ज्यादा या ओके दैट्स गुड बस या so we have just taken our first of the angios and now we are going to be starting
Yes, sir.
working on the device
ग्राफ खोलें
ग्राफ खोलो
Right, sir.
खोलो ना
32 13 166
चल यार गणेश क्या राजकुमार आया नहीं क्या 9:30 बजे का उसने बोला था 10:30 हो गए
16 नहीं 32 13
13 नहीं है 16 यही है Yudhvir, one of you open the device.
Sir, so, sir, what's the plan for SMA, sir?
So SMA, we are just going to make some 3-vessel fenestration now.
Okay,
So
sir.
we are going to do a fenestration for the SMA as well as both the renals.
Right, sir.
The SMA and the right renal will be from top, and the left renal we will cannulate from down below.
Yes, sir. I think, sir, left renal is arising from aneurysm.
इसी के अंदर है बस इसको इधर ले लो What is that? ठीक है ठीक है ठीक है ठीक है, कोई बात नहीं, उसको वहाँ पे रखने का, लिफाफे को संभाल के रखना, इधर ही रख लेते हैं अभी, कोई बात नहीं, इधर खोल लेंगे, फिर उसके बाद मैं वापस रखता हूँ। डॉक्टर अजय को भी देना, ठीक, उधर स्टूल दे देना, उधर स्टूल दे। स्टिफ फायर चाहिए एक, यदि स्टिफ फायर दो, एक स्टिफ फायर है इसमें, क्या है यार ये, आई नो इसमें बैठ ही नहीं सकते हैं यहाँ पे, तो इसको उधर ले जाओ, इसको उधर ले जाओ, स्टूल दो। इसके तरह सा स्टिफ फायर डाल के, लेट्स जस्ट सी वेयर ई मार्कर कहाँ है, we will make the fund just underneath the E marker, जहाँ पे E marker है वो तो सेंटर 12 o'clock वही होगा।
उनको उल्टा करके ठीक है, आवाज आ रही है।
उसी को मैं रिवर्स करके लगा डाल दो।
Contra will be on this
Contra
side.
will be E will be on the other side, sir. Back side हो जाएगा ना?
Right side. ये marker right में आएगा ना? This marker will be right.
Till then we are setting the table up for modifying the
marker.
E marker will be on that side. E marker will be
I will
here.
show you how the EVAR guidance
center,
looks.
Center.
अपने को spotlight करो.
E has to be in the center. हाँ, front side में आएगा ना?
Till then I will show you how the EVAR.
चलो आगे, टूल आ गया.
Can you see the image in the PIP?
I'm just opening the device now. यहाँ पे, यहीं पे सब रखा था.
थोड़ा सा सलाइन डालना है, थोड़ा सा सलाइन डालना पीछे से,
हल्का सा.
Nikhil, can you see the image?
Nikhil, stiff end डालना है, बस थोड़ा सा, बस. ये वाला.
No, Ganesh, no, image is not visible.
Sir, can you see the? Yes, sir. You can on the screen. Can you see the EVAR guidance image, sir?
We have to.
We can see.
I have spotlighted it. Yes. So that is the EVAR guidance. We have a EVAR guidance software so that we can see the origins of number one. This number one is the celiac, followed by SMA. On the 9 o'clock position, we have the right renal. On the 1 o'clock, it's left renal. So now we are modifying the graft. So I'll just focus on that now.
हम्म 60 बाद में चाहिए, मैं वो भी चाहिए पहले एक नंबर 30 प्रोलीन 30 प्रोलीन भी एक चाहिए 30 हो जाए लाइगेटिंग द 30 हाँ yeah so this we are just securing the top tab.
Sometimes barbs tend to slip out of the cap.
Okay.
Move the thread. ये contra इधर है सर.
Contra इधर है, वही है. इधर I am going on the side only. Yeah, somebody, they can hear us? Ganesh? थोड़ा सा मतलब जहाँ पे flow divider, we don't have to open the entire thing.
Bedi sir, we can hear you, sir. Ajay sir, we are...
Okay, great. So we are just opening up the device. Then we have a few things to do. We will just open up where the about 4 centimeters down below.
Yes, sir.
Nish, can we bring the camera closer to the graph?
Yes, sir.
We will
We'll get more.
Very
We'll
far.
zoom in.
No participant is able to see what is
Yeah,
happening.
we will just show you.
We'll just, sir. I'll just zoom in.
Ajay is making some hole, I think, through the artery.
One second.
They have to make the 3 holes and
थोड़ा सा नीचे तक
it should be visible to the
just
participant.
यहाँ पे flow divider है थोड़ा सा और just to get our artery faucet through. कुछ zoom कर दिया ना? Okay, now. Yeah. So
Sir,
now
can you
we
see
have.
now?
So this is our
A little bit better.
Yes, sir, we can see it, sir.
So now what we have done is we have come up to the flow divider here. This is the contralateral limb which is there, where the ring forceps has gone through.
Yes, sir.
So without opening the complete graft, we are just going to put a ligature. So I'm just going to take a suture out here and transfix the graft. इसको ट्रांसफिक्स कर देता हूँ पहले ट्रांसफिक्स करता हूँ.
So, sir, this is the proximal part of the stent graft.
The flow divider. This is the flow divider.
This is lower part. Okay.
Yeah.
This is the
So
flow
what
divider.
I will do is
Yeah.
double-ended. Okay. So what we will do is we will just put in a couple of sutures. Sorry. Please, can we have some conversation?
Right, sir.
As Bedi sir and Ajay sir are modifying the graft,
Yeah.
meanwhile, Dr. Apoor and Dr. Nikhil has already placed the long sheath from the right and left brachial. So thereon, I think we'll use the left brachial for SMA and right one for pre-wiring.
Ganesh, have you taken any DSA or something?
Nikhil, your volume, his voice is very low. Can you speak up?
Hello, Ganesh, have you taken any DSA?
Yeah.
Yes, we have taken a few DSA.
Please show that.
I can show you.
Please show the DSA. Yeah.
Yes.
Right angle. Right angle. Yeah.
Right now, fluoro is on. So after that, I'll just show the DSA images.
Right. So cannulation has been done?
No, cannulation, we have just put in a long sheath. And after that, we'll put in we'll try to cannulate.
Long sheath from both the brachials?
Both the brachials. From the left brachial, we already placed the long sheath.
Nicely.
Right, we are doing.
Okay, so we have taken 7 French on left and 6 on right. Am I right?
Yes, I need to check it because I'm outside the lab.
Please. Yeah.
Now let's look for the E marker. Scale दूसरा वाला दो या ये नहीं दूसरा छोटा स्केल कहाँ है? ये रहा.
Okay. On the left side, we have 790 long sheath.
Okay.
In the right, we are taking 6.
Yeah,
That's the one.
Okay. Right.
Correct. So this is our center point.
And we have exposed the left common femoral artery.
ना?
दिख रहा है.
Yeah. Okay. Tape कहाँ है? Measuring tape.
Exactly center of this.
No, but this should be actually located towards the right. But ठीक है. तो सर ऐसे भी करोगे. हाँ ठीक है.
E marker के नीचे
The only thing is this limb has gone on to the other side now. हाँ मतलब थोड़ा सा लगेगा उसको. Are you sure? This is E marker.
pointing towards the contrast. ठीक है.
तो कॉन्ट्रा हमारा राइट में जाना है.
हाँ, तो इससे करेगा.
Okay.
Then we'll lose orientation. So we have to use the other marker then.
ठीक. So let's use this one.
Only minus point is this.
Yeah.
We don't have a. क्या तो ये cross है. We can use this.
वो मैं यही बता रहा हूँ. We have to go 1 centimeter below that.
Mark. क्या दिया?
मतलब दूसरा वाला है यार.
ये ट्रेन एक मिनट ट्रांसफर वाला पेन और मार्कर कीजिए. आप सुपेरियर वाला क्यों देते हैं?
तुम्हारा स्टैंडर्ड जो अपना वो कहाँ है? टेप इतनी बड़ी जो
टेप कहाँ है?
इसका कैसे बता दो सब वो. And the see 1 centimeter below that we have to go ना. चलो anyway. This one is है इसमें. This is 1 centimeter is there. तो इस स्टफ में हमें बनाना पड़ेगा.
Bedi sir?
इस वाले में. यार निखिल. हाँ.
Bedi sir, can you hear us?
This
Sir?
is the top of the
Yes.
line. Yeah, Vika, I can hear you. Okay. So here.
So right now we are trying to make a fenestration for this one, sir. SMA, sir?
Yeah. Yeah. First, we are making the fenestration for the SMA.
Hello?
So I'm just trying to get the measurement.
Yes, sir.
So we will use about, this will be now an 8 mm fenestration. So I will be making the mark. This is the center point of the fenestration. Okay. So here I'll be creating my first fenestration out here. And I'm going to use the bovie cautery. Wait a second. All these really jokers to give me that measurement. क्या measurement? तो 3 दिन पहले तुमको बताया था कि ये सारी चीजें चाहिए. ठीक है. This is fine. 8 मिलीमीटर साथ ही होना. थोड़ा सा बड़ा कर देता हूँ. इधर की तरफ. Yeah. Okay. दूसरा वाला भी बना ही नहीं क्या?
So we have a good number of participants, around 53.
Okay, good. So this is 12 o'clock. No, one sec. जरा सा मेरे को एक बार देखने दो. That is पेपर को लाके दिखाना. We have to come down. Now what we will do is we have to see our next fenestration. We will just mark them out. Left renal मेरे को दिखाना. एक ऊपर. Left renal is at 249. That's 8 millimeters below the SMA at 1 o'clock. Left renal. That is the approximate.
Right, sir.
So now this is the lowest part. So 8 millimeters will be somewhere out here.
at 1 o'clock. 1 o'clock, 2 o'clock.
So
Plus
this
all
is
the
for the left
local
renal
tough
artery.
melon.
This is for the left
Uh,
renal artery.
Left renal. Left renal is a little at an angle. We have to go from down below. The only thing is कि 1 or 2 के बीच में लेना आ जाए उसको. Feel you should take it there exactly. That will be much better. हाँ.
अगर ये 12 है तो ये 1 है.
मुझे ये 1 इसका टिप है ना उस तरफ ही रखना पड़ेगा. 132 के बीच में ही है. We'll keep the left renal here. Okay, so that's 8 millimeters down there. Yeah, 8 millimeters. So this one is now right renal is 256. So that's about 15 millimeter down below.
And 3 o'clock. इसका ये है. 3 o'clock is this sir. ये यहाँ है.
15 millimeter देख लेते हैं. एक सेकंड. ये यहाँ से 14, 15.
ये यही है.
हाँ, उसमें नीचे की तरह आएगा लेकिन हमें उस वाले
ये है ना.
हाँ, नहीं इसके ट्रफ में जाना पड़ेगा. हाँ,
this is 1.5.
15. हाँ हाँ. Because the ट्रफ में जो है हमें नीचे की तरफ जाना है. That is the top of the 256 is top. Down below is bottom. 249. Then otherwise we will go a little. हाँ, ठीक है.
1.5.
वही है. मुझे ये वाला. फिर वो नीचे वो हमें फेनेस्ट्रेशन नीचे चाहिए. 249 तक जाना है.
इसको यहाँ
यहाँ से जो पॉइंट जो है ना, if we take it from here, हमें नीचे की तरफ जाना है. We have to go up to 249.
नहीं सर 249 तो राइट है, लेफ्ट है.
हाँ लेफ्ट पे तो हम राइट पे कर रहे हैं.
हाँ राइट पे कर रहे हैं.
256 है सॉरी.
256 है.
256 है. That is SMA से 240 15 मिलीमीटर वही.
हाँ वही था.
हाँ.
15 मिलीमीटर हम इस ट्रफ में ले सकते हैं.
फिर नीचे भी तो जाना है.
थोड़ा सा हायर.
थोड़ा हायर रखेंगे. ठीक है. फिर थोड़ा सा हायर रखेंगे. ठीक है.
एंड 3 o'clock पोजीशन में चेक कर रहा था. 3 o'clock इज ठीक है सर.
हाँ. या इसके पीछे 6 है.
ये 6 है.
ये 6 है. This is 9.
Look at you.
हाँ, that's right.
And
Yeah, you're 9 o'clock. ठीक. This is 9. ठीक.
इस ट्रफ में लेते हैं.
ठीक.
एंड थोड़ा सा ऊपर ही रखेंगे.
ठीक है. इसको भी बना ही देते हैं. फैन बना ही देते हैं.
एक सर के सारे सेट करेंगे.
हाँ, दे दो. वो देना. वो भी. हाँ, वो भी. This we are making 5 mm.
This is 5.
Okay. दिखाना मेजरमेंट.
खुलेगा भी.
हाँ.
ठीक है.
4, 5 की कर लिया. थोड़ा सा सर्कल को हल्का सा बढ़ा देते हैं. हाँ मेरी तरफ भी और थोड़ा सा तुम्हारी तरफ भी. ठीक है. ये 5 मिलीमीटर हो गया. ठीक है ना. वो भी.
Bedis.
Yeah, Nikhil. We are just. We are just.
Yeah, I think to answer the Dr. Prashant's question, we have planned this fenestration according to the 3D reconstruction CT angio images we had. Yeah.
Good morning, sir.
Yeah. Morning.
I think the on-field penetration is going on. Of the aneurysm because some participants have joined late. So is it okay that we review the angiographic pictures by the time they finish?
Yeah. Yeah. They are already working on the other side also on doing the angiography and getting the. We are just pre-wiring the vessels which are there, the SMA and the right renal. So I don't know. We are not watching that part. they can definitely show that. I think Ganesh can show that in PIP.
Yes, sir. Yes, I can show it, but I think fluoro is on. After that, I'll just show it.
Yeah.
Sir, suturing is being done to prevent the extension of ear.
So what we are doing is we are going to be taking interlocking sutures out here.
Yes, sir.
Your image, it's in the PIP. You can just touch on the PIP. You can see the angio image. DSA images. Nikhil, can you see it?
Yeah, we can see the angio. Yeah, DSA images.
Yes, this yes.
Yeah.
You want CT angio images?
Yeah, I think people want to see that also.
Okay.
Cities will also do, yeah, sure. I think we are
Yeah.
planning to see the angio.
Yeah, I'll just show the CT images.
Yeah. You can just put any one camera in the console, Ganesh. You have that 3D image in the console.
Nikhil, can you see the CT image?
Ganesh, I think
Yeah,
you could have shown that from console. You have that in console.
Yeah.
Yeah, this is visible.
This is okay?
Yeah.
This is
it's,
okay? Okay.
Yeah,
Hey,
it's okay.
You can
can
see.
make it larger a little bit?
So the rest, common iliac is occluded. The patient is not symptomatic for that side. So we have placed the long sheets from both the brachials, and we have exposed the common femoral. And after we are ready with the graft, then we'll start the next one.
इसीलिए इसीलिए यूज करना था। इसको हाँ लेके इसको कर दें। Now you can bring it in. नहीं आएगा? Okay. चलो आगे आगे आया नहीं है बट अड़ गया जो भी है। हाँ it is already there. Yes. Next वाले में दे दो। Next time में दे दो।
Vedi sir,
Yeah.
there is a question from Dr. Swadesh. He is asking, like, can you just explain the suture technique around the fenestration in short? Just in a
Can
brief.
I explain the?
Suture technique around the fenestration.
So what we are doing is we are taking continuous sutures with 6-O-proline, and they are all locking sutures, because since this is a Dacron fiber, we don't want any threads and all to come in. So that is the reason what we are doing is we are taking continuous sutures, and now we are almost reached the end of the fenestration out here.
Any wire to for
That's a
radioluminescence?
coronary wire that we are doing. Yeah, that's
Okay.
what we are using, a coronary wire. It's got a radio opaque tip out there, and that is what we are looping around the fenestration. So what Dr. Ajay is holding right now is the wire. So getting that wire, and now we got both the ends of the wire now. Take it from there, Ajay. Take it from there. I want you to just take it. I'll hold it there. So what we have done is we got a wire across, and we complete the ring out here. And this little bit of the redundant wire which is there, we will just trim it off now, because I think we are good now. What I'll do is, while Ajay is holding, yeah. So a little bit of redundant wire which is there, we will just cut it off with the bone cutter. और सब दूसरी वाली दे देना, ऐसा कुछ दे देना चाहिए। हाँ बस ये first. I think we are good. Yeah, ठीक है. So this we are done with one fenestration. Cutting.
balloon to 7
Balloon कहाँ है?
7
सिलेंडर खाली सिलेंडर खाली सिलेंडर.
So these coronary wires are the loose wires, over 4.
So now, sorry, using the wrong order for you.
Dr. Jan, you can just touch the PIP down.
Okay.
So
now we have just injected some air into that one. I think it's a leaky balloon. It's a leaky balloon. नहीं यहाँ से तो कुछ right. So this we are just checking out. leaky balloon है. चल ठीक है. Anyway, इसका काम नहीं है बाद में. Let's go on to the other one now. While दो एक और. एक और दे दो, ये चल जाएगी. नेक्स्ट वाला फिर से नया चाहिए होगी. वायर एक और चाहिए. वायर एक और चाहिए
Naga 60 proline, please.
3 रखो ना.
Vedi sir, it's on the left renal, sir. This one, this fenestration.
Now we are going on to the left, right renal. This
Right
is the
renal.
SMA fenestration, so we are going on the
Okay,
right
we're
renal,
going right renal.
which is a 9 o'clock position. So again, this is again a two-man job.
Yes, sir. It requires great precision also.
But we will just show you. We measured with a.
Yes, Dr. Shawn, we are planning for pre-wiring fenestration.
So we will be pre-wiring one of the vessels, not really both of them. Because you don't want to have too much of wires and all cluttering up your picture. So the plan would be to go ahead and pre-wire the right renal, because that's going to be a little smaller fenestration, and we are going to. The right renal is a better artery. AC थोड़ा सा बढ़वाओ. Yeah, same here. What's the progress on that side here, Kapoor? Okay.
And SMA cannulate करनी है.
Sir, Dr. Hemant is asking how to decide fenestration size. How much
Fenestration size.
How much smaller than the stent graft size?
So it's always 1 millimeter smaller than the stent size. So when we make a fenestration, like for the SMA, our plan is to put in an 8 mm Bentley graft. So we'll be doing a 7 mm fen, because what happens is when you make the fenestration a little smaller, when you do the wiring also, you got a wire out there, you're always going to be making the hole a little bigger. Plus when your stent comes inside, you want the stent to be nicely placed. So the hole has to be a little smaller than what is required. Because when you're doing this overlapping bit out here with the suture, you're making it about less than a millimeter wider only.
Okay, sir. Sir, Dr. Harita is asking the precautions while resheathing.
Well, she will know when we are doing resheathing and all.
Yes.
Let's not put the cart before the horse.
Yes, sir.
First, the step is to get the fenestrations right. Then the resheathing part is the next bridge that we have to cross once we come down to it. So what we have done, as you know, that we have already. So that's why we put a couple of silk sutures on the top cab. We got a stiff wire in the lumen, because when you're doing this, you don't want to break The nose cone.
And the cautery which is being used is an ophthalmic cautery.
Yeah, that is a bovie cautery. That's why I think it's very cool. इसके अंदर वायर के थ्रू गया है. So this is like what a tangle web of story this is. इसमें से ये इसमें से भगा दिया होगा. इसमें से सूचर में से कैसे चला गया? हाँ. What a tangle web we read.
Sir. Vedi sir.
Yeah.
Morning.
Sir, this exposed part, does it go back into the sheath easily after the fenestration are sutured?
Yes, there is a technique of doing that also.
And is there a length that much only we should bring it out?
We have to come back and try that. Sorry? Yeah, we have to.
We will not unwrap the whole stent, na, Manish?
Okay, sir.
Whatever the length is required for the fenestration, we will unwrap that only, and then we will deposit it.
लाइट थोड़ी बेटर हो सकती है.
लाइट को जरा ऊपर से दिखाएं.
Yes, this is fine. हाँ, अभी ठीक है. Sorry, यार अपना हाथ हटाना है कि हरीश?
कर दिया प्राइवेटली.
इसमें से ले लिया गया. ले लिया गया इसमें से आ गया गया. इधर फिर से जाना पड़ेगा. सूर्य वायर को काटना है. ये वायर का स्टिफन को काटना है.
Taking the wire beyond it.
Sure. You want to take this wire?
इसमें ठीक आ गया.
हाँ, निकल गया ना. स्टिफ पार्ट है वो. I think इसको डिवाइड ही कर देते हैं. वायर को. या
Meanwhile, Dr. Apoor and Dr. Nikhil Sharma have placing the CXI catheter from the right brachial to the groin. So we have taken an Endurance 2, 32 into 16 into 166 stent graft from Metron.
Ganesh, where the aneurysm is ending on the
balloon, छोटा balloon. हाथ खोलो. Syringe के साथ में. Syringe. खाली syringe.
Hello, Ganesh.
हाँ जी.
Ganesh.
हाँ जी, बोलिए संदीप. Yeah. So we are just now checking the. Now you can see we put in a 5 mm balloon into the fenestration and we are seeing it well engaged. So this is something which is very, very important because it should fit in
Yes,
well. Yeah. Now we will go on to the third fenestration, which is the final one.
For the right
And then,
figure. That is at the 9 o'clock position.
no, this is 1 o'clock position.
No, no, sir. Right.
This is the third one. This is 12. This is 1 o'clock. That is 9 o'clock. Stitch it over. Stitch it over.
Dr. Vijay, the graft is not a custom made. We are modifying it.
Okay, great. Okay, good, 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 good. ठीक है, बहुत बढ़िया.
Somebody wants to show
Yes,
the
we are.
range of pictures, we can show the range of pictures.
हम लोग now we are on to the final fenestration.
Right, sir.
Take open 4 wire.
वो रख दिए, coil वाला दे दिया, दोनों mandrel.
Mandrel, coil wale, coil pusher.
Other consider. To go from this side first. Wanted to take it from this side, or you take it? Not under. Yeah.
V40 में मुझे command ES देना. मुझे command ES दो और mandrel wire दो. Coil pusher होती है, homemade coil, जो load करने में काम आती है. 2 देना. Rotate करो ग्राफ.
Vedi sir.
Yeah, Ganesh.
Dr. Vijay is asking. Dr. Vijay Richard is asking, how much time does it take for the bench procedure, sir? on an average?
You are seeing it, how much time is it taking? I don't know what's the time like, because we don't really look at the clock. But I guess approximately a fenestration takes about 20 minutes or so. So each fenestration takes about 20 minutes. So I think considering that we got to do 3, I don't know what the time is right now. So I think we are almost around, we started making the fenestrations around, I think after 10:30 only.
Yes, sir.
Yes,
So I
sir.
think
Then we are about to complete
We
the
have
third
reached
one.
third fenestration. Yeah.
yeah.
PT
So
pass is, I
now
think, only 40 minutes. Sir.
so far that's what it is. So now we are just trying to finish off my part of. So as you can see, as you keep doing, your hand also start moving faster. So we have a good rapport out here that both of us know what the other person is required to do. So you don't have to say anything and all. I think that's the most important part of having a wonderful team.
Yes, sir.
Each person knows what the.
Here I can't. I'm not sure if I'm audible.
So now I pass the baton to Ajay. So he goes on to the home run now. Ganesh, Dr. Ajay is not able to hear. Just check his audio.
Yes, sir. Yes.
I can't hear. I can't. I'm not sure if I'm audible.
Hello, Ajay sir, can you hear us?
Can you hear me?
Yes, sir.
Yeah,
We can hear you.
I can hear. But Ajay's voice is not coming through the.
Yeah, I think we can hear us, sir, from Vedisa's Bluetooth.
Yeah.
AirPods, I guess. So I'll check the sir's connection again.
Yeah. So I think now we are almost at the end of this fenestration, and we will again cross-check. Yeah. बलून 5 वाला फिर से बलून देगा ना just hold the wire hold the wire ठीक है just fine it's okay.
So meanwhile, Apur sir is trying to cannulate the SMA from the left brachial. If you want to see, you can see on the VIP down. You can click on that.
इसको पता नहीं है just want to be sure. Okay, so this again we have checked with a 5 mm balloon. We are good out here. As you can see, this is quite snug.
Yes, sir.
Dr. Vijay, we have used 60 proline.
for
Sorry. I'll just do it. ठीक है चलेगा
1/4 wire
ये रख लो सारा सामान umbilical tape
So, sir, we are pre-wiring right renal.
Yeah.
Ganesh, now this part should be shown to the auditory participant very clearly.
Right.
How the cotton tape is wrapped in the bits and it is slided.
इस वाले से ले लो मस्कीटो
अंदर में वायर डाल देता आप देख के
Yeah. There you go. So this we will just pre-wire Watson chain देना है ज़्यादा नहीं डालना है इसको डालो मैं अभी जैसे रीशूट कर लेंगे तब अंदर डाल देंगे हाँ that's it. Shall we? Umbilical tape ये सब बता दो चलो ये रखना वॉटसन चेंज रखना हाँ नहीं अभी तो जरूरत नहीं है चलेगा प्लीज मैनेज
somebody come here make sure this doesn't get
वायर को जरा से देखना वायर को जरा से बदल देना ऊपर इसी में ले लो इसमें नहीं आएगा
just hold this wire like this
हरीश इसको पकड़ के रखो चलो हाँ डिवाइस को पकड़ के रखो हाँ you want to first ये वायर को ना ब्लॉक स्क्रीन पे रहने दो
दोनों
मैंड्रिल दे दो
मैंड्रिल दो so you don't do anything except
ये ब्लॉक पे हाँ वहाँ पे कहाँ तक पहुँचे
ये समय नहीं दिख रहा है सर
समय नहीं दिख रहा
एकदम माहौल में से आ रहा है
चलो ठीक लेते हैं अभी this one उसमें से डाल फाइबर
Can you please explain the wiring?
So we are just putting in two wires to get the alignment of the fenestrations ready. So these wires are somewhere around 9 o'clock on this side. And what we have done is we just pre-wired the right renal. As we go along, we will just yeah.
taking photo कहाँ है मुझे कहाँ है आपको फोटोज के लिए बाकी किसी को खड़े होने की जरूरत नहीं है यहाँ पे सिर्फ जो फोटो ले रहा है तो वही रहेगा या जो एक्चुअल में कुछ हेल्प कर रहा है
ठीक है क्या हुआ? इसको थोड़ा सा और एक काम करो, इसको you want to come down here, once इसको निकाल के I'll do it here.
ऐसे ऐसे
हाँ ये ऐसे जाने है ना, ऐसे रखो, इसको ऐसे रखते हैं, ड्राफ्ट हमसे पता है। हाँ ये क्रीज में जाओ, इस वाली क्रीज में जाओ, ज्यादा अच्छा। या हाँ
इसको ऐसे रखो,
जस्ट ऐसे पकड़, ऐसे दोनों को पिंच कर ले। हरियम कौन सा, कौन सा मस्कीटो देना, मस्कीटो देना। हाँ okay, yeah. Sure. Yeah. Now we are at, this is 12, yeah.
This is how it will be.
याद रखना अजय, मार्कर जो है इधर आएगा ये वाला। हाँ कंस्ट्रेनिंग फीचर्स देखते हैं, कंस्ट्रेनिंग में से लगा देते हैं, प्रोलीन देना एक बार जरा सा लगा ही देते हैं, बहुत एक्चुअली लगा देते हैं, एक तो चीज लगा देते हैं, थोड़ा सा लेके फिर कर देंगे। प्रोलीन का स्टिचेस रखना जरा सा। इसको बाहर को ना एक मस्कीटो पकड़ के रखो। आई टेल यू व्हाट इज डू, मस्कीटो दो, we'll just hold it with a mosquito. Yeah. अच्छा एक काम करो, just hold it like this, नहीं गिरेगी ना, बाहर नहीं जाएगी। ओके पूरा स्ट्रेंथ तक ही जाना पड़ेगा।
एक बार ये अंदर चला जाए। So as you can see, it's an umbilical cotton tape which we are rotating around the graft, just inserting the graft, and simultaneously we resheath it from down.
This is बाद में डालते हैं, ठीक है चलो। And now resheathing अजय, we have some gap out there. Okay, I'm just pushing it. Watson chain रखा है ना यहाँ पे।
So while resheathing, while we are just putting the umbilical cotton tape around the graft, we have to make sure that all the barbs are inside the cotton tape.
Yeah, okay.
So that it will be easy for resheathing.
Okay, holding. चलो थोड़ा सा अंदर ला लूं। गैप ठीक है ना? ओके ओरिएंटेशन तो अजय राइट में आएगा, मार्कर तो देख लिया। दिस इज कमिंग, दिस विल कम ऑन द राइट साइड,
दिस विल कम ऑन द स्ट्रेट साइड।
वो घूमता रहता है ऊपर है ना? ठीक है हाँ
ठीक है
छोड़ दो कोई बात नहीं, बाद में कर देंगे उसको। चल अम्बिलाइकल टेप
मुझे ये बाहर को रखना है,
ऐसे
रखना। आपने अगर उंगली से उसको दबा रहे हैं,
मैं दबा रहा हूँ
नहीं इसको बस
या आई डू दैट। एक काम करो ना, वायर को ऐसे ही रोल कर दो इसके अंदर जो है। एक सेकंड, जस्ट डू इट। मैं पूरा नहीं कर रहा हूँ, जस्ट वन रोल अराउंड। हियर यू गो। ओके, हाँ वो बाद में काट देंगे वायर को। ओके ओके, थोड़ा सा गैप आ गया। मैं पुलिंग बैक अ लिटिल बिट। करिए, आप दिखा देना मुझे थोड़ा सा। या ओके, थोड़ा सा आ रहा है। या ओके, गोइंग फॉरवर्ड।
So meanwhile, if you can see in the PIP, in the angio PIP, you can click on that. Dr. Apur has cannulated the SMA and taking MPA now and exchange with the O14.
अरे वही मैं बोल रहा हूँ, इसको जो है ना पकड़ के इसको यहाँ पे रखे रहने दो, इसको बाद में इसके अंदर पैकेट कर देंगे। See, I can't see the wire. One second,
Ladies, sir, one is the coil pusher and one is the wire.
Yeah, we are just pre-wiring. That is the right renal के लिए pre-wiring. We use the wire out here,
so
which
coil
we will
pusher
just keep it for the coil pusher is just to get the alignment of the fenestration. But right now we have taken it out.
डाला, sir?
Well, that is just kept at 3 o'clock and 9 o'clock position.
अच्छा.
Yeah, that is just to get the alignment के लिए. So that ठीक है हाँ, वो जो ये तो इसका तो अलाइनमेंट छोड़ दो, इसको ही रखना हमने कुछ टाइम। ठीक है, ऐसा में तो बेल्ट ही है। अच्छा, या इट इज जस्ट फ्रॉम देयर ओनली। थोड़ा सा पुल बैक करना है। इसकी सब जगह बना लो। हाँ, अब नाउ दैट इज अ लॉट बेटर। या दिस इज फाइन, दिस इज फाइन। या ठीक है। कंस्ट्रेनिंग लगा दें एक बार, तरह से कंस्ट्रेनिंग स्विच लगा देते हैं, दैट विल बी बेटर। कंस्ट्रेनिंग स्विच लेना तो हरी स्विच दो, एक लंबा वाला प्रोटीन का
60 जो बचा हुआ है लंबा।
हाँ ठीक है, यहाँ से ले रहा हूँ।
स्टेशन के बीच में आएगा, ठीक है, वहीं
पे चाहिए।
हॉस्पिटल को वहां से देते हैं।
थोड़ा सा रोटेट करना पड़ेगा। ठीक है, ओके, here you go. अच्छा, ओके, मैं छोड़ दूँ। हाँ, एक कंस्ट्रेनिंग के नीचे से लाना है ना।
We are using 60 proline as a constraining suture.
चलो हिल होल्डर प्लस 2 थोड़ा सा मोटा यूज करना चाहिए
तो थोड़ा सा ऊपर नहीं, ये नीचे ऊपर वाला यहाँ और ट्रस्ट पे नहीं सर, ट्रस्ट पे स्टॉप
बहुत ऊपर चले जाएगा
नहीं। अच्छा
वही तो बोल रहा हूँ।
अच्छा सॉरी
बहुत ज्यादा
दूसरा दे दो भाई। अच्छा इसमें है
है वही सोच रहा था
नहीं सॉरी, आई गॉट ओरिएंटेड टुवर्ड्स
यहाँ पे ले लो इसमें मस्कीटो लगा देना क्या पे यार कोई एसी थोड़ा सा बढ़ा सकता है एसी क्या मैक्सिमम पे
दरवाजा बंद कर दो।
हाँ कोई बात
Just 3 or 4 bites, sir, for the constraining suture.
just going around every alternate strut that we go
Every alternate, sir. And that this is below the fenestration.
This is between the two fenestrations.
Okay, between the two.
So this is just going so that this just even when we deploy the device.
So we'll break this by a coda.
Yes.
This is Ambarish.
Yeah, Ambarish.
No, just to add to what Tapish was saying, the other advantage I think with the constraining sutures is that it gives you a little space between the target vessel and the device, so that when you, for whatever reason, if there is proper alignment between the fenestration and the target vessel, you still have a little space for the catheter to come out and then seek the target vessel. That's the sort of additional.
Okay, so half opening of the stent, then you have a vision, pull out the sheath, and
just an added sort of benefit, because you can just peek out of the fenestration and then then look for your vessel. Because if it's completely abutting the wall of
then it becomes difficult.
It becomes.
Although you have a this guiding this thing, the rings are made already, but still.
Yeah. I'm talking about the target vessel. Penetration on the target. Let's say the renal or the so if it's constrained, the device.
Yeah, if it is abutted, you won't be able to see. So if you have space, you will be able to see.
रीनल को भी कर सकता है तो कर दे, बट तेरे पास टारगेट है वो है, हाँ ठीक है ना तेरे पास, हाँ तो राइट रीनल भी कर दे, बेटर है, then at least we have our orientation right there. डॉट येलो सेंटर में है अभी. ठीक है, हमारी वायर इज आल्सो वेरी हेल्ड आउट देयर. या
तो तपेश
अच्छा ठीक है, रहने ठीक है सर, दैट्स गुड. एक अच्छा लगी तो देन वी आर गुड. बस अभी ये कंस्ट्रेंट हो जाता है तो देन वी गो इन. ओके
तपेश,
थोड़ा सा गैप है
सर.
हाँ,
just to say that earlier we were quite enamored by the crimper, and now we seem to be so comfortable with this, as you're seeing that almost seamlessly Dr. Bedi and Dr. Ajay.
Yes, sir.
Just pushing it back a little bit, Ajay. थोड़ा सा पीछे जा रहा.
And all of us are quite conversant with this
okay. This is good. Okay, going up.
And physical crimping with our fingers.
Yeah. Okay. I'm just stopping because your gap is also increasing. Hand squeeze. Yeah. I'll just pull back. No problem. I'll just get that. Yeah, it's okay.
I think, Dr. Satwik, this part is more important than the this thing, or equally important, I think, because this is the whole planning.
Half the operation is what
Half the operation depends on this. If your configuration, if your diameters are right, then the rest of the task becomes easy. Otherwise, it's a
absolutely.
you know,
And
you're just lost.
About your question of the coil pusher bits that are placed, because we are physically constraining the endograph, you have to be absolutely sure that you're taking it inside. Okay.
Do we wet this a little bit or not?
Yeah. Okay. नहीं वो थोड़ा सा इसको गैप को खत्म करने के लिए now I'll forward.
About the coil pusher forming a spine on two
थोड़ा
parts.
सा push कर रहे हो.
So because we are physically crimping it with our fingers and then applying the umbilical tape and then resheathing.
हाँ उनको दिखा दो जब तक. हाँ बिल्कुल दिखा दो.
Be sure that twisting happening internally, because otherwise the alignment of the fenestrations will completely change. Okay. So which is where the coil pushers placed at pre-designated places will help immensely.
So when you're crimping, it should be lying, when the configuration should not change.
Yes, the coil pushers will ensure that, you know.
Yes, sir.
ये वाला ले लेना स्ट्रक. ये दूसरा वाला आ जाएगा. Okay. Right. Just show me this part down here. Just pulling back a little bit.
नहीं सर
अब जाऊंगा.
गैप कवर कर दूंगा यहाँ.
Okay. Pushing. जा रहा है.
सर गए नहीं इधर का नहीं गया.
इधर का दिखाना. हाँ.
बाहर सर बैक करिए.
ठीक है चला गया. चला गया.
नहीं इधर का रह गया.
Dr. Apur is here. He's just explain about the access and for the angio what we have done now.
Hi sir, Dr. Satwik.
हाँ चलो.
Dr. Satwik.
चले गए ना.
I can hear you. Your voice is not very clear. Who's my voice?
यहाँ पे जगह बनानी पड़ेगी.
चलो मैं आगे पुश कर रहा हूँ. हाँ हाँ डिप्लॉय कर रहा हूँ ना. रीशीट कर रहा हूँ ना. कर रहा हूँ. थोड़ा सा गैप आया फिर से.
Sir, can you hear us, sir?
I can hear you, Ganesh.
Yes, we can hear you, Ganesh.
Yeah, Dr. Sandeep, good morning, sir.
Good morning, Apur.
Yeah. I just what
Apur, you are not audible at all. Ganesh, please do something, because Apur's voice is not audible.
I think, sir, Apur's voice is not audible due to that mask.
Apur, I think making that very mask.
I think what you can do is,
ठीक है.
Ganesh,
चलो काफी. ठीक है.
Yes, sir. Yes, sir.
Because your voice is quite audible, what you can do is let Apur you, and then you should speak out on behalf of him, because Apur's
बस ये थोड़ा सा रह गया अभी. ये वाला स्टार्ट आ जाएगा ना. दो स्टेप्स. ये वाला बचाओगे इसके बाद वाला.
Yeah, I can hear you, Apur, but it's muffled, not very clear.
Going there. पे आएगा ऊपर थोड़ा सा गैप आ रहा है. थोड़ा सा पीछे लेना पड़ेगा. इसको थोड़ा सा अंदर लेना पड़ेगा. थोड़ा सा बैक करके हल्का सा. हाँ ओरिएंटेशन ठीक है. मैं थोड़ा सा इसको हल्का सा पीछे ले रहा हूँ ताकि रिड्यूस द गैप. वो तुम्हारा अभी वो तुम्हारा स्ट्रक जो है ना ये अटकेगा. चलो चलो ओके गो. थोड़ा सा ना चलो करता हूँ.
Can you can you tell us what has been done till this point? I can see you've cannulated the SMA.
Yes, sir.
उसके ऊपर से देना, उसको तो स्लिप कर रहा है स्ट्रट के ऊपर से थोड़ा सा स्ट्रट हाँ ले ठीक है नहीं ठीक है ये सारा का सारा ठीक है.
We have calculated the left SMA.
Yeah.
Sorry, SMA from the left brachial.
Right.
Okay. I'll just show you that thing, sir. Just a second.
Okay. Now we are on the last part. Hello.
Yeah, sir.
Can you hear me? Now we are on the last part of the.
Yes, sir. I can see that. This is Ambarish.
So we are just getting. Yeah, Ambarish, I know. Yeah. So just getting the last of the struts in place because this is the most important part.
Yeah.
That get your struts nicely covered.
Right.
And this time you got to be very careful of
Right.
not bending the olive also, and at the same time,
right,
just getting all your stents nicely in one piece without breaking
the
olive. So
I was briefly.
Ganesh, the bench is not visible, Ganesh.
Yeah, yes, sir.
Ganesh, make the bench one spotlight.
अंदर डालो या ओके तो कितना ऊपर वाला डालो.
Sir, bench is not here, sir.
Okay.
Ganesh, you have to maximize the bench work.
Yeah.
Can you see it, sir?
मैं आता हूँ उधर से. Yeah.
We can.
Where is the bench visible?
Yes, it's visible.
It's visible, but it hasn't been spotlighted.
Yeah. So you just need to tap on that.
Okay, right. Yeah.
You need to tap on that, sir.
Okay, got it.
Now it's fine.
That's fine.
इसमें एक सेकंड भी मिस करना ठीक नहीं है गणेश. इस समय का जो है एक सेकंड इम्पोर्टेंट है.
हाँ ठीक है. रोल करना है ना आपको. हाँ ये करो. हाँ ठीक है. Yeah. Okay.
Dr. Satwik?
Yeah, I can hear you.
Yeah, now you're able to hear me?
Yes, I'm able to hear you. Yes.
Yeah. So I can take you through the angios up till now, what we have done.
हाँ अब इसको वो कवर्ड वाले पार्ट पर लेके जाना है. क्या पतला हो गया थोड़ा सा ना गैप तो नहीं है.
Apur, sir, you're showing the angios now?
Yeah, Dr. Bedi, sir.
Yeah, Ambarish. Yeah.
You can see a wire coming out. Has it been pre-wired? One of the.
Yeah, we have done one pre-wiring of the right renal artery.
Yeah. Okay.
Yeah. So now.
And I was briefly missing through this. Have you scalloped the SMA or?
No, we have created 3 fenestrations out there. We made 3 fens.
Okay. Okay.
So because scallop wasn't working out because the gap is very less between the SMA.
Right.
And
so I hope, Tapish, you saw how the pre-wiring was done.
Yeah, I saw that. I'm just Apur, just 2 minutes, then we'll come. Just let us see the bench, and then we'll come to the angios, because this is the last part that sir is doing and making a flat tape here.
This is the last part.
Yeah.
Just getting a dissector to get the last bit of the stents, the struts.
सबसे जिद्दी part. Yes, sir.
This has been after a great deal of exertion by Dr. Bedi, because
No, Ajay is doing the maximum hard work.
I know.
Yeah,
I'm only doing the easy bit right now. So now I think we have been able to blade.
Yes. And you
So
would
now
have
we've
seen
been able to resheath the entire graph. And what we will do is we'll take out the silk suture, which
Right.
we had.
So that Tapish is the silk suture which is restraining the top cap.
And now we are removing the mandrel also. So now we will just, the device is now all set for use now.
looks good, sir.
Yeah, so far so good.
The one thing you
And it's,
must be careful about Tapish,
इसको इसके
yes,
अंदर
sir.
डालो.
always
इसको
check
इसके अंदर
the
रखो.
end of the endograft
Yes, sir.
if it is abutting the pusher in the device.
Taking out the.
If there's a gap there, that could be a
चलो
problem
device ले ही चलते हैं.
during resheathing. When you are unsheathing, it's a self-ex stent, effectively.
Yes, sir.
So the
So
pushing
now we need a.
in touch should be touching the.
लीक कर रहा है यार ये. शॉट दो यार.
So yeah, Apur, now I think you can run through the angio
Yeah,
phase.
yeah. Apur, we can go through the angios now.
I'm just taking out the sheet. We इसी एक के साथ में एक वो गाय डाल देते हैं इसी के थ्रू. आपके के थ्रू. ये arteriotomy है ना.
So, Satwik sir, you can just, by the time they come to the angios, what is the sizing that you do depending on how many fenestrations? What is the percentage more than the desired stent graft size that you do?
So fundamentally, I think, more than the sizing, it's the alignment based on CT tomography. That's important.
जैसे वो बता देना जब वो निकल आगे.
You have to be absolutely. So I think
pulling.
about a 10 to 15.
ये आपने flush किया था
for sizing.
चलो अभी.
Work.
निकल.
Not
Okay, sir.
Stop now.
exactly the same.
Pulling.
Because you wouldn't want them to,
Pull out the catheter.
Okay, pulling that.
Take it out.
Now, can we go through the angios after they are done?
चलो.
The angios of cannulation and the rest of the, he has taken a wire from the right brachial into the left femoral.
catheter डाल के. We'll have to change the sheet ना. इसको निकाल देते हैं. उसकी sheet निकालनी थी. We'll have to pull back the wire. Catheter को वापस डालो. Catheter वापस चलाओ. That's what I was thinking. Using one step. कोई बनेगा कुछ.
से चढ़ा रहा हूँ. Hold this. आने वाला होगा सर.
अभी तक तो नहीं आया. चल.
हाँ सर वायर तो है मेरा.
खत्म हो गया. कैथेटर कहीं लीक कर रहा है तुम्हारा. आ गया. Okay. That's it. ठीक है. Pulling out the wire. We'll pull out the wire.
हाँ wire left.
Taking out the
Leave
sheet.
the wire. Leave the wire. Leave the wire.
हाँ.
Left sir. वायर खत्म मेरी साइड से.
ठीक है.
ये प्रेशियस वायर है बहुत ज्यादा. ग्राफ्ट के
शीट को
अंदर से आ रही
निकालना
है.
ठीक है. फ्लोरो किसके पास है?
Back on live. Over to you very.
कलर बेटर नहीं हो सकता क्या इसका? काला क्यों आ रहा है इसका? काला क्यों आ रही है इसमें?
So we taking this into what?
I think
We just take note. We just have to take the device now.
Sarkar
You have the renals now.
is this a sheathless main body deployment? Yes, it is a sheathless device. This is a Medtronic device.
Okay. That might be the angulation also for that matter. That might be the other double.
Actually that is the angulation.
You want to take the catheter? चला गया. ठीक है. सेव कर लेना इसको. You are taking out this catheter. You have to take out the catheter. So that's the only way we will take out the sheet. Na? अच्छा लुडिकस डाल देंगे, ठीक है मैं डाल देता हूँ. Yeah, that's what I'm saying. चलो.
10 French. अच्छा नहीं.
Still going bareback only? Okay, sir. No, ठीक है, ठीक है, ऐसे कर दे. चलो, sir. यहीं पे रखते हैं और क्या, ऊपर जाने की जरूरत ही नहीं है, बिल्कुल नहीं. Okay, yeah, that's it. Yeah, something to go. The request will go through the stent.
Okay.
And this one we will just.
The wire that was used for pre-wiring?
We have not changed the Lundquist wire now.
Okay.
So now through the same puncture site, we are going to take the pre-wired wire also into the right brachial back again through the CXI catheter.
So you're using the right brachial for the pre-wiring of the left renal, you said?
Correct.
Yeah. So I hope Tapish, you're tracking that.
I'm tracking. Previously, they had done a right brachial to SMA.
Okay,
Yeah.
pulling.
So what
Straightening it.
What pre-wiring does for the benefit of the participants in the audience,
Pulling.
that you've got a wire that is
Pulling.
going from the right brachial. Okay.
Pulling.
That is
Okay,
managed
stop.
to pass through
Let's take the device.
of the device,
Catheter
so
को pull कर रहा हूँ.
top cap of the device into
Pull
the
back.
device and out of the fenestration of the
निकाल लो.
Understand that.
Suction कर देना
सर पूरा निकाल
और
दो.
साफ कर देना जरा गणेश.
कैथेटर पूरा निकाल दो. उसके ऊपर
Sorry.
वर्ड दे दो. वर्ड. ठीक है.
ठीक है.
वर्ड. इसके ऊपर वर्ड चढ़ाओ जल्दी से. एक जना वहाँ जाके हेल्प करो. थोड़ी सी
डिवाइस ले चलते हैं थोड़ा सा. Let's take the device. इसको थोड़ा सा कैथेटर को थोड़ा वायर को पुल करो. निखिल you have to keep in tandem now. Be here. हाँ तो वायर को पुल करो. You have to get out that loop. हाँ keep pulling.
निकालो.
और पुलो. लेते रहो.
कैथेटर चढ़ा उसके ऊपर वर्ड.
बस just stop out here. मैं चलता हूँ. इसको देख लेना. हाँ.
Make God soaking wet. अभी. Let me get a catheter there.
Okay.
I need a catheter to support the. No.
Where is the orientation? अजय ये हमारा orientation. Okay. चलो अजय मैं.
Orientation पर अभी देखते हैं सर.
हाँ. तो किसके पास है?
आएगा आपके पास वर्ड आएगा. तो हमारे सामने ले लो इधर. नीचे दे लो. नीचे चलो.
नीचे आ जाओ.
नीचे पूरी डाल दो यार अंदर. सर ये थोड़ा सा तामझाम ऊपर हो सकता है. I need some working सर्विस. पूरा खत्म. वही पूरा खत्म.
हाईलाइट में है.
Hold the wire please. बाहर. I need my working सर्विस. थोड़ा सा इसको अपनी मशीन को पीछे ले लो. अभी डॉक्टर इस पे लगा दो. ठीक है. फ्लोरो सर. ओके. नीचे दिखाओ ग्राइंड पे. सर आप ओरिएंटेशन सीधी कर लीजिए.
ओरिएंटेशन कर लिया है सीधा. आई एम टेकिंग द डिवाइस अप.
विल मूव इन टैंडम.
या
होल्ड द वायर. समबडी होल्ड द लुड्रिकस.
Ajay, you have to keep pulling the wire.
हाँ सर मैं कर रहा हूँ.
Soaking wet gauze piece.
215. एक मिनट, मुझे एक बारी पहले फ्री करा दो मेरी लूप
तुम्हारा अपना लूप हटा दो।
और वह पुल करिए सर, ध्यान से।
हाँ पुल कर लो अजय, पुल 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 ओके, दैट्स इट। नाउ
ओके, देखो इधर करो यार, स्क्रीन एक जना
ढीला है
सारी स्क्रीन खुद रख रहे हैं
यार, इसका ओरिएंटेशन यार निखिल, दिस हैज टू बी 12 o'clock। ओके
एक मिनट
हाँ
ठीक है, ओके एक मिनट
हाँ
ऊपर दिखाओ, ऊपर यस, क्या कर रहे हो युद्धवेद?
ओके ठीक है, वायर तुम्हारी कहाँ है?
ओके
That seat has to be pulled, sir.
हाँ वो मैं करूंगा, टैंडम में चलूंगा।
चलो
यस सर। युद्धवेद सामने दिखाओ, एसएमए में है ना?
ऐसे में।
ओके विवेक, इसका वो कहाँ है? ईवार
बढ़ाओ इसे,
होल्ड करके रखो।
बैकअप
मैगअप करके हमें दिखाना,
Backup
मार्कर
दिखाओ
दिखाओ, ई मार्कर दिखाना है यार।
मेन स्क्रीन राइट करो।
हाँ ठीक है,
राइट साइड की सीट थोड़ी पीछे आ गई, समय के बाहर आ गई, सीट अंदर डालने को लगी।
हाँ
वायर है सर,
एक सेकेंड,
एक मिनट
फ्लोरो
यार, राइट की मेन स्क्रीन कर ली फिर।
Okay, let me just see, let me align the graph Ajay.
हाँ सर,
This has to come in this
नहीं
position.
सर, आप उससे करिए,
किससे करूँ?
फेनेस्ट्रेशन से, टॉप फेनेस्ट्रेशन से।
एक मिनट, अभी जरा सॉफ्टवेयर हटाओ जरा से एक बार। फेनेस्ट्रेशन ये सामने है, फेनेस्ट्रेशन ये सामने है ना, ये
कौन सा कैथेटर, कौन सा ये 100 है 125 है? 125 कैथेटर कौन सा है?
अजय ये फेनेस्ट्रेशन तो ये वाली दिख रही है, एक बार फ्लोरो करके दिखाएं। फेनेस्ट्रेशन ये रही, I'll just see if that is the way. This comes to the center. See, ये बिल्कुल ठीक है, because the reason is left renal is the one which is at 1 o'clock, that's a little higher up, and the right renal नीचे वाली है. So this we are okay here. Sorry. ठीक है, कोई बात नहीं. Never mind, we don't want the sheath out there. तो हमें तो
So, sir, this is Ambarish.
yeah,
So we don't have a wiring of the renals done in case a chimney is required.
yeah, we haven't done that.
Yeah.
So we are using the alignment of the SMA.
No, I'm just saying that let's say a backup option in case.
Well, that's why we have thought that we will keep it, because if our SMA falls in place, then automatically we should be able to get across into the.
Logistically, the only thing would have been that in case you would have had to keep at least one of the renals or both renals rewired for a chimney, we would have required.
Yeah, but then the problem is that you need more accesses. That's the only thing.
Or possibly have an auxiliary
Go a little up.
so that can accommodate two.
हाँ, काफी ऊपर जाना है, मैं वही तो वायर पकड़ो.
So I was saying, sir.
Yeah.
One of
so
the
normally we do that also.
Auxiliary.
But here, you know, considering that we are using the EVAR guidance software.
Right, sir.
And this is what we saw.
Yeah. So I was just trying to tell the participants that in that case, the brachial action will not work.
Otherwise, we use that also.
Auxiliary.
We generally do the pre-wiring also. And what we can do is, once we are able to cannulate the SMA, because we are not releasing the device completely, we will do one thing, that we will take back that wire from the SMA.
Right.
And we can use that for cannulating the right renal also.
Right, sir.
और ऊपर जाना है? फ्लोरो यार, फ्लोरो इधर दे दो. I think we are fairly high up, Ajay. हाँ नीचे तो आ जाएंगे बट ओवरले का गया ओवरले दिखाओ युद्धवीर हल्का सा नीचे आना because we will see the yeah okay celiac वही है we are just above that we are just above that we are perfectly placed for cannulation absolutely yeah so let's I think so because location wise we are absolutely fine out here okay I think यहीं से deploy कर रहा हूँ okay ठीक है अजय
For the benefit of the audience, as you would have seen, the device is slightly north of the designated target SH.
Yes, so we'll pull down, sir. After first string deployment, we'll pull down.
You can pull down also because we're cannulating from above.
Yeah.
Catheters are looking down, and it's much easier to cannulate the SMA and the renals.
Right.
The designated for deployment.
Right. Okay. Yeah, absolutely. में आ जाओ yeah SMA is right renal भी बिल्कुल बिल्कुल हल्का सा नीचे आ रहा है वही this is absolutely spot on this is spot on okay just hold your finger out
Tapish, all three fenestrations can be seen. I hope you.
Yes, we can see that, sir. Beautiful.
मुझे ये देखो ना contralateral gate ये रहा हाँ हमारा E marker
the SMA is anterior, the
right
left renal is at around 1 o'clock, and this is a little posterior, the right renal, and as I said, around 260 to 70 below that.
Right. If Ganesh is at the console,
fluoro. Yeah. Okay. Hello. Yeah. तो इसी पोजीशन में मैं कर रहा हूँ मतलब खुलेगा ना वो
प्रभु
Yeah, we can see angio Ganesh.
Yeah, we just lost the connection.
Yeah.
So again,
Yeah, yeah.
We're able to see.
We can see.
Ganesh, nothing is visible on the screen.
सर वो एनजीओ दिख रहा है सर, वो हाथ वाली स्क्रीन बंद हो गई है शायद.
Right one is
No. Angio जो है, this is not coming on the main screen.
You can click on the angio, sir.
No, we are seeing the angio, but this is not coming on the main screen.
This is
Yes,
not
sir. Yes,
some,
I'll try to connect again. Till then, I think this will be okay. Dr. Nirmal, you can click on the PIP down below. You can see the angio image on it. Sandeep sir, is it you can see now, sir?
Angio is visible, Ganesh. We can see the angio.
Okay.
We just need to click the PIP or swipe to extreme left.
that's okay. Don't worry about that.
We'll try to reconnect with the main one.
So I can see that catheter was wired catheter is already out of the fenestration. Dr. Bedi, sir? Tapesh, can you?
Sir, yes, now we are on the main operating screen. The angio is gone.
Dr. Bedi, sir?
Can't see anything on the video panel.
We can switch to the console, Ganesh.
Sir?
Okay.
Can't see the angio.
See, sir?
Yeah. Okay.
Yeah, now we can see the angio.
Fenestration is has been crossed by the pre-wired catheter.
Yes, sir. We can see the sheath also coming over the catheter. It's a long sheath in the right renal fenestration. The tip of the sheath is just at the tip of right renal fenestration.
Nobody move. Please stay here. Stand here.
Satwik sir, the constraining suture is still in there or it's not there?
Now you can see the angio clearly, more clearly. We have
Yeah, we can see the angio. Yeah, we can see the angio also. And in PIP, we are seeing cath lab.
Dr. Harita, is it clear now, sir? Is it clear now?
Yeah, we can see the, I think this is left brachial. Trying to cannulate the left renal fenestration.
Okay, what catheter is being used from the left side? Dr. Bedi, sir?
Satwik sir, that is a MPA.
Okay, great. Where is she going? So I can see that I think the sheath from the right brachial has managed to come out of the fenestration. Ajay? Or just at the mouth of the fenestration, I think. Yeah.
Yes, sir. I think it's just at the mouth. Sir, what's about constraining suture, sir? Is there still?
Not just yet. You know, once you have, so see, think about this. Look at the aorta.
Yeah.
Because of the constraining sutures, the graft is slightly crimped. Okay.
Yeah. No, I am just asking, sir. Is it there yet? Yet it's there.
Opened it. No? They'll need a coda balloon to. They'll need
to break the
to
suture.
dilate the
Yeah.
So just think this
Yes,
is
sir.
for participants. Once you come out of the fenestration,
Right, sir.
there's some gap between the fenestration and the target vessel or
The
the
wall.
There is
Yeah.
some space for you to play around, some latitude for you to turn right and left and seek the target vessel as you come out of the fenestration. In case they're not perfectly aligned.
Yes, sir. Yes. Sir, so they are planning to cannulate the SMA from left brachial.
एयरपोर्ट निकाल के मेरा उसमें प्रॉफिट नहीं है वो अंदर जाएगा उसको उसके ऊपर एक रीड के ऊपर ट्राइपॉड लगा दो ऐसे नहीं लगा दे ट्राइपॉड लगा दो सामने उधर लगा दो ना ट्राइपॉड लगा दो वॉल्यूम बढ़ा दो कैन यू हेयर मी
Yes, yes, sir. Yes, sir.
Okay. So right now, I think we have entered. No, we have not entered. We are just trying.
Not, sir.
Outside.
Yes,
Just
sir.
trying to see that without deploying the top cap, if we can enter the stent graft. But I think there's the problem out here is that always the space between in the top cap is very little.
Yeah.
So we are just trying to see if we can.
So just a suggestion, sir.
Yeah.
Ambarish. So I think the wire is entering the graft.
No, no. The wire is not entering, Amrish. The wire is not. The wire is going freely down into the aorta.
No, earlier on
So,
the attempts, it was.
Yeah. No, it was not really. It was just getting hitched out there.
Okay.
But you see, because we are coming from an angle from there, the space in the top cap is very limited.
So now, do you think the wire is inside the graft, sir?
Well, no, not really. As you can see, the wire is outside the graft.
Okay.
So that's why I feel that probably it's a better idea to deploy the top cap. So I'm just waiting. Ajay wants to try for a couple of minutes more.
देख के खोलना आनंदी देख के
Perhaps a different catheter, Ajay. Perhaps a vertebral or a Picard.
No, we needed a 125 catheter. So the thing is, unless and until the wire goes, there's nothing that will go down. You see.
Right.
So the challenge is to get, because we have.
Actually, it is pointing much towards the left.
Yeah. Rotate the catheter. Rotate.
Yeah, I think yes.
Yes, going out. Outside. Other way. Ajay.
Sir, sheep ले ले थोड़ी आगे.
Ajay, you are making life more complicated. You know. Now the wire is still outside. You know, इसके top cap के बीच में gap is very less. See, the thing is that you have to get inside one of those struts, and the challenge is if that strut falls on that side, then nothing will go down. I think so. ठीक है? Okay. फ्लोरो? नहीं कुछ नहीं करना. चलो. We still have constraining sutures there. Okay. एक सेकंड अभी चलो कर दो, सेव कर दो.
Right, sir. The top cap is open. Yeah.
Yeah. Now I'm inside the.
Now he is inside the stent.
Yeah,
and now you can see the fenestration is also opened up very well.
Yes.
We are gone.
Now I think Ajay has entered also. Ajay has entered. Save this. Save karo.
This is the SMA that is being cannulated.
SMA, sir. SMA.
Yeah.
So, yeah. It's gone from outside.
I think it's gone between the struts or from inside or something like that.
Yeah, now he is wedged inside the graft. Now, as you can see, the wire takes a loop.
Yes.
So, अब मैं तो डिवाइस को तो छोड़ सकता हूँ. तो theoretically now I can leave the device now. Yeah, I think this is a good angle. तेरे पास कोई वो
और एंगल वाला
बर्नस्टाइन टाइप नहीं है कोई कैथेटर? Yeah, now you're just catheter को अजय रोटेट करके try pushing it inside and just एक बार रोटेट करके पूरा दिखा दो, एपी में भी एक बार देख लो। तो या हिटिंग एपी में ज्यादा अच्छा आएगा, दैट्स व्हाट आई फील। एपी में आ रहा है यूजुअली। Yeah, you're knocking, but you are just take a puff of contrast. Just take a puff of contrast. You'll know where you are. Yeah, yeah. यार एक एंगल वाला कोई कैथेटर नहीं है? हाँ दो, ये वाला दो, दिस इज बेटर। तुम्हारा बर्नस्टाइन टाइप कुछ नहीं है कैथेटर? हमारे पास पड़े हुए हैं, दिखाओ। हाँ ये दो। बर्नस्टाइन हमारे स्टॉक में थे, जो डॉनकास्टर से आए हुए थे।
हाँ ये बहुत ही गाइडिंग की तरह लगा है।
So the good part is that we still have the constraining suture, so the stent is not fully open. But as you can see, the E marker is right now dead center, the fenestration is dead center, and the right venal also is in good position.
Yes, sir.
We are just, the only thing is to get the right catheter inside.
Sir, floor.
What is the size of the sheath on the left side, sir?
Sorry?
What is the size of the sheath on the
seven? That's a 7 French sheath, 790.
790. And that's got the wire outside for the chimney as well, right? From the left side?
Yeah, that's what we did. We just kept Apoorv had gone across with the wire and cannulated the SMA.
Right.
So now what that's a good landmark that we have. Now just Ajay is just getting his catheter inside.
So
into the graph.
So I think one visceral will require sequential testing.
So probably we are tickling the other wire now. I think we are through now. Possibly. We are through. So I think this is done. Come kar do. So now as you can see that change of catheter, great skills.
Yeah.
So now I think we are through the fen and we are nicely into the SMA. Take a shot. And we will just take a shot now.
Lose the smaller wire.
Now I think one of the viscerals will have to be tackled sequentially because you.
Yes. Now we will be once we just do, we'll just cross check. and see that we are nicely inside, then we can lose the other wire once we get our sheath inside. So what Ajay is doing right now is taking the long sheath inside.
No, I meant that, because you don't have a cut down in the axillary and we just have, so one of the viscerals will have to be tackled sequentially. I mean, all three can't be done at the same time.
Yeah, right.
So the sheet can't go in till I remove the 014 wire.
So we will have to remove the 014 wire now, but the sheath is not going inside.
Have we taken a cut shoot, sir?
Sorry?
Have we taken
Now we are in. No, we will just take a shoot now. Now we have just gone, we are just at the mouth of the fenestration. We have entered the fenestration. Now we are across the fenestration. Safe. So now we will just take out the wire, or rather we'll take a sheet shoot only because it's a 7 French sheet. So it's a little occlusive. I think it's better to take it through the catheter. Yeah. So we got a good blood flow in the catheter. Max 32 kar do. 32. नीचे दिखाओ. Yeah. So we are nicely into the SMA.
Yeah. I can see that's it. No, my question was, sir.
Yeah.
Now that both sheets are engaged in both fenestrations.
Yeah.
The left renal remains to be cannulated.
Yeah.
It will have to be cannulated once the two stents have been deployed. Because
right.
Now.
Yeah, that's right. We will be deploying 2 stents. So right now, you see, because you have a catheter and a wire across, the renals are still flowing through.
No. I meant left renal.
Yeah.
Now we don't have any other sheath left because both brachial, both sheaths.
Yeah. So either ways, Amrish, the plan was to cannulate the left renal from down below because of the bad angulation.
Okay. Fair enough.
We had never planned for doing the left renal from the top.
Fair enough.
Because that was a bad angle. It is only going to be able to. Going to be possible only from down below. That is already. We had planned that way.
Okay. Right.
Now we will just take a stiff wire.
हेपरिन देने का टाइम है सर. एक हेपरिन दे दो.
2000 हेपरिन और दे दो. $2,000 हेपरिन और दे दो.
2000 हेपरिन दे दो. Give me 827. 827.
827 or 37 is good.
Ganesh, there is some box on the screen.
27 is good enough. You don't need a very long one. Let it. बिल्कुल.
That's good.
827 दे दो. Yeah.
So the sheath in the right renal is not moving.
Sorry.
The sheath that is at the mouth of the right renal fenestration.
Sir, that is
sorry.
Sir, that is actually at the ostium. We are not trying to push that in right now.
You're not trying to push that in. Okay.
Yeah.
Stiffer है क्रॉस. ठीक. Sheath has got a little this thing.
ये इसको प्लस करो. खींचो पहले एस्पिरेट.
डायलेटर रेडी है उसका.
तुम हटो ना.
फ्लश कर दो. जल गया.
सर मैं एक बार उस वाली शीट को करूं. हाँ. एक ऊपर. वो 2000 का भी है. आई भी दे दो या तो ऊपर से. अच्छा ठीक.
इसी में शीट में डाल. करो. तो 2000 Uterine दे दो, B ग्राफ खोल दो। एक सेकेंड, 827 अजय नहीं देते हैं मेरे ख्याल में।
मैगअप करना ऊपर दिखाओ
सर अपने लगेगा सर, बोलता हूँ सर, अभी बोलता हूँ, अभी नहीं सर अपने
बढ़िया, 827 is more than enough.
ऑफ
But we are seeing both the renals also, right? Renal is also nicely seen. Left renal दिखी कि नहीं पता नहीं.
राइट वाली तो फ्लो हो गई है.
Left वाली को देखते हैं. अरे हाँ वो कर देंगे, वो that we will do it. That's no problem. पहले डिवाइस डिप्लॉय करना है ना पहले.
डिवाइस डिप्लॉय करके उसके थ्रू पर वो ले जाते हैं
नीचे से आ रहा है.
बड़ी वाली शीट रखो जरा सा रेडी. बड़ी शीट रखो रेडी. प्रिपेयर दैट. नहीं वो जो शीट है अपना ड्राई शीट इधर लेके आओ. निखिल, यू नो व्हाट इज टू बी डन विद द ड्राई शीट. यू नो हाउ टू प्रिपेयर दैट. आई विल प्रिपेयर दैट. सिस्टर, ड्राई शीट इधर लाके रखो. एक 20 cc सिरिंज के साथ में मुझे उसको फ्लश करना है, फिर उसको क्या ले लिया शीट बाहर. मोर देन enough. Absolutely, more than enough. No, अजय. हाँ अजय, इसको डिप्लॉय करी तो पहले खत्म कर दो. नहीं होगा, ओडा बलून से क्रश नहीं होगा, तो हमारे ठीक. तो हमें भी स्टैंड चलो ठीक.
Once the stents are inside, we
साइमल्टेनियस डिप्लॉयमेंट कर देंगे, करके वायर वहीं पे छोड़ देंगे, बलून को भी वहीं.
Is this a big?
सर यस बेंटली सर.
B graph.
Yeah, and
sir, now we are trying to get the sheath into the right renal ostium.
yeah,
The catheter is already there, the wire is there. We're trying to get the sheath in.
contrast, please.
Contrast.
बड़ी मैच काम करो. आप 20 Supracol stent is behind one of the bombs. प्लीज ऐसे लटका फटका के नहीं चाहिए मुझे. सुप्राकोल की खाली कैपिटल की. इसके बाद मुझे 6
so for the benefit of the participants, I think it's important.
Yes, sir.
I'm just telling the participants that one has thought about a backache in the sheath.
Right.
It's very possible that the sheath can develop clots, especially
Exactly.
for a long time.
Right. Right.
So now you can see that the sheath.
It's short though.
637 दे दो. 638 38 रन लिखाओ पिछला वाला. नहीं ये वाला. हाँ इसे चलाओ फिर. I'm not sure where my even मुझे even खोलना नहीं. Contrast. Yes. But I just want to take it. The origin कहाँ है? I think close by. Sir, apnea के लिए ready? Yes, sir, ready. Apnea? अभी नहीं. Off कर दो. चलो. On कर दो. Wait, you tell me on or off? On sir. Apnea on. सांस रोके रहे. Mind is 57 on. So simple reason sir. Sir, aneurysm ना यहाँ ये vowel है या ऐसे 30 वो 27 है ना 8 सेंटीमीटर वो में 37 थोड़ा सा aneurysmal एरिया में है सर ऐसे साइड ये ऐसे तो खुलेगा अभी तो और खुलेगा तो पास ही आएगा छेद दूर है ठीक है 37 837 637 नहीं वो अभी तो खुलना है ना ये अभी तो और पास आएगा बॉल फ्लश करके दें पीछे से So then you deploy everything, get CUDA in, capture the and then I start deploying the stent. Renal peak it is between the sorry, what are you doing? Fluoro, please. वायर को थोड़ा सा पीछे ले तो वायर पीछे लो बस ये कर सकते don't going ये तो और स्टेट की तरह आना है नहीं आती सर अब आप डिप्लॉय कर दीजिए ठीक है ये ना आ रहा जी आप ऐसे में वाली आएगा नीचे लेना लेफ्ट ड्रॉ लिखाऊंगा मैं काम कर दूं फिर कितने पे 32 पे टेबल 2 पे आ जाएगा ऊपर लिखा ना ऐसे में वायर आओ वायर पूरा नहीं थोड़ा सा पुल बैक पुल बैक keep telling me pull back keep pulling pull stop
सेव कर लो सर इसके अंदर सेव कर लिया यस सर सेव कर लो सर My renal sheath is behind the leg. यही है Bring the whole device inside. Put your on the drawing. नीचे फिर इसको हटा के टाइप करेंगे इसको पहले हटा के देख लेते हैं तो 18 गेज है हमारे पास नॉर्मल 18 वाली दे दो इसमें ना आपको थोड़ा हाथ से लाइन का प्रेशर बना के रखना I'm not removing my hand or moving in the hand. So, tension हो तो बिल्कुल stable रखना है. कहीं नहीं. Lifeline है.
The contralateral limb will be tied off.
Sir?
Contralateral limb will be tied off.
It has been tied off. That has been tied off, sir. Opposite limb. That was the first step of modification.
Good morning, sir.
No reason why you should be struggling to पीछे से उसको पकड़ के रखना गाड़ी नहीं सर 18 वाली दे दो नॉर्मल 18 दे दो नॉर्मल 12 दे दो 12 अच्छा 14 चाहिए 18 वाली दे दो 18 वाली हाँ दे दो 14 दे दो ये वाली ब्लू वाली 14 और स्टेंट हमारा पास जाएगा बहुत तो जल्दी करो
So, sir, do you want to take a shot to see if the penetration is already the ostium of the left renal?
We have already checked that. We have already taken shots of that one also.
Acha, sir, ठीक है.
Yeah, we've taken shots of that one.
So, while the sheath is being attached to the left groin, can someone just
we have a Satwik, we have a we have a constraining suture. So unless we break that suture, we can't deploy any of the strains.
No, I know that. I'm not saying that. I'm just.
Sorry, I didn't get your question then.
I just wanted to see the alignment of the left renal fenestration with the left renal, if they can play the angiogram. Now, if they've done a, if you've done
No, we haven't cannulated the left renal. We don't know what to.
I'm not saying you've cannulated. I'm saying the position of the fenestration And are
to
you
the
able
renal.
the left
No, we
renal?
haven't taken a contrast run of the left renal, so we have only taken right renal runs.
No, that I've seen. That's what I wanted to know.
No, left renal we haven't checked anything so far.
Okay.
So once we are through with deployment of all these, and then we're going to come back and do this from the groin. The aim was because it's at an odd angle, it's on the dome of the aneurysm.
Yeah, of course. That's clear. Right.
So the reason was to do that was so that it would be easier to cannulate from the groin.
Right.
Wire लुंडोकोस्ट ऊपर चढ़ाएं. एक मिनट. ऊपर दिखाओ पहले wire.
Ajay sir, good morning sir.
Hi, morning. Good morning.
Sir, Vivek here. I just missed in between.
Sure.
Are these wires going inside the graft, sir, for the right renal and SMA?
Yeah. Absolutely.
Okay. So before, when you did it after opening the graft?
हाँ जी. Sorry. When are we going to deploy it?
Sir.
We are going to deploy it once we break our. हो गया होगा. Because we have a constraining suture, so we can't deploy our stent grafts unless we have inflated the coda balloon once. Because these are all balloon mounted stents. As soon as you deploy the coda, it will crush these stents.
Sir.
So you understand why, despite having all the stent grafts in and the stent, it was between the renal and the SMA.
I want to know at what point you cannulated the right renal and SMA?
Once we had deployed the stent and opened up the top cap.
Okay.
Sir, I'll do the right renal. No, sir. कोई जरूरत नहीं है. नहीं. Okay. Let me deploy the right renal. Floor, please. Okay. Just a contrast, please.
Yes, sir.
Yeah. Mark करो. Center करो. Center. Yeah. आपने सर? Yeah. Apnea off. Okay. Position. Yes, sir. 9, 13 है सर. 9 normal है, 13 आर्बिट्रेरी. यूरिन आउटपुट कोई देख रहा है ना? हाँ. From my side, everything is proper.
Ajay.
Hi, Apu. Hi, Ambarish. Sorry.
That seems like a fairly long stent in the right renal. Any particular reason for choosing?
It's an aneurysmal part of the aneurysm.
But the angio
5 centimeters.
The angio that you put like the fenestration was not in the renal. You did a check shoot.
But initially it looked as if it is pretty far, so we had taken the stent in much before that.
Okay.
But I believe once the gates opened and the constraining suture came off,
okay.
It looked much better. So, but anyway, in retrospect, yes, to even 27 could have been possible.
Go lateral to the SMA.
So I think we're just going to take a contrast run of the right renal. Renal को center करके दिखाएं. Back कम करो. Back कम करो. Apnea please. Apnea please.
Apnea on, sir.
That looks okay, Amrish.
Yeah, we just
Back on.
perfect, pretty good. Yeah.
Get the wire out. I think let's get the hardware out. I'm trying to get the hardware out of kidney as early as possible, Amrish.
Of course.
No. So, yeah, I'm just going to other side for a estimate.
Apnea.
Sir, apnea. Apnea. Back on. Remove the sheet निकाल लो. इसको कर दिया था फ्लश. You need the smaller sheet. सर ये निकाल दो. कोडर में निकाल लो. वायर निकाल लो. वर्ड में वायर डाल के रेडी कर दो. और दूसरा जो इधर पॉइंट दो. अरे यार यही नहीं करना यार. Satwik sir, are you there?
I'm there.
Yes, so sir, we're trying to cannulate the left renal from below.
I can see that.
Right. I think we'll have to take a longer sheet for support.
Yeah.
That is the plan right now.
Yeah. Also, you just want to take a puff there just to see where the renal is?
Sir, what? Can you come again?
You want to take a puff there just to see where the target vessel is?
Right, sir. I think we will do that. That is it. Angle कह रहे हैं, angle. Sir, we're taking a contraster now.
Apnea ready?
We couldn't see the run very well.
Sir, we could not visualize the left renal. So we are trying to come from the top sheet now. Sir, are you there?
I'm there, I can hear you.
Yes, sir. So we could not visualize the left renal arteries from below
I
here.
saw that.
Yeah, so we're trying to come from top and
Can you see now?
Yeah, but not the operator view. One NGO view is there.
Yes, sir. Yes, sir. Yes, sir. We had some network issue again. It got disconnected.
Sir, yes. Raise correct.
Go back to the audio.
Have you plan to take a shot from above?
सर अब नीचे दिखाओ चलो ठीक है ठीक है
Have you taken a shot from the brachial?
Not yet, sir. No shot from the brachial.
ठीक है
Sir, आप ready shot के लिए? हाथ से थोड़ा पानी डाल दीजिए कोई. I think you are there in the retro area.
Is that going into the renal from outside the stent graft?
No, sir. That is a celiac.
Okay, that's the celiac. Yeah, it's fairly high. Yeah.
एक सिंगल ट्रैक करके अगर जा सकते तो बस go with the tip of the wire, just gently nudging it.
Satwik sir, angio is clear now?
Yeah. I think is outside the stent graft. Can you hear?
कोई बात नहीं आ जाएगी शीट को वहीं रखो शीट को नीचे दे दो
Sorry sir, Satwik, what did you tell me?
The catheter from above, the wire now from above is outside the stent graft.
Yeah.
Yes, sir. Where the wire is in the retro-stent area between the stent and the outer.
You're trying to see if you can see where the renal is from there?
Yes, sir.
Are you trying to take a catheter there to see where the renal is?
Yes, sir. Exactly. I think that is the plan. Meanwhile, we have taken a Picard from below, trying to cannulate it, the left renal ostium.
I think you managed to do somewhere.
Yeah. The wire has gone inside.
Thought that had gone into left renal. Nikhil? Ajay?
Satwik boss. Dr. Satwik. Satwik sir. Ganesh.
Yes, sir. Yes, sir.
Dr.
Hi,
Satwik
sir.
हैं क्या?
Satvik sir was here only.
Satwik sir was here. Wire has entered somewhere. Catheter has gone across the left renal fenestration.
Wire has gone. Wire is in the aneurysmal part.
Yeah.
So
Hello,
we'll
Tapesh.
take a run. We'll take a run
Sir.
from here.
Tapesh?
Sir.
Anji, you are going to ask something or you are searching Satwik, I think.
वो ओपीडी पेशेंट देख रहे होंगे सर अभी मल्टीटास्किंग एक इंटरव्यू चल रहा
नहीं. Satwik is not in OPD today.
अच्छा
Satvik sir is at home, I guess.
सात्विक सर एक पेन पेपर लेके प्री वायरिंग का जरा बना देना डायग्राम सर पेन पेपर लेके सर राइट रीनल की प्री वायरिंग का एक डायग्राम बना देना
We can just take it on a vote and then we just come back and then take it. यहाँ से लेके गिरेगा नहीं। सर मैं यहाँ से ना आपको और एक्सेस दूँगा। I want to give you stable access. आप vote से change करो। vote को करने का। ये
Apnea, yes sir, apnea on.
origin of it.
Apnea off.
में ऐसे नहीं आएगी ना, 80 में तो इंटीरियर नहीं आएगी. तो I think इसको आ रहे हो.
Apnea on. Apnea on.
Because at least if you give us that new rate, even growth rate is
Sir, I'm seeing that photograph that you have sent on the group. Just seeing that.
For the participants, I shared schematic of rewiring the WhatsApp. Okay.
So,
take a look and let me know if you understand it.
So the extra wire that is there, it is you wind it up with the umbilical tape. The extra wire that has come out.
Now, what you have to imagine is that the wire basically, you unfurl the device, then you put in a wire through the fenestration in a way that it enters the device and comes out through the
So one is coming from the sheath from the side, and one is coming through the fenestration and folded in the umbilical tape.
Yeah, so I'll tell you what. First, unfurl the device, unsheath the device. Okay.
Yeah.
Make a fenestration. Now you put a wire in through the fenestration so that a little bit, about 2 inches, stands out outside the fenestration.
Okay.
Or outside the device. The
Okay.
rest and
no, the extra tip of the wire, say 5 centimeter, is folded and entwined in the umbilical tape.
No. First, we'll talk about the umbilical tape right now.
Okay.
This bit of the wire is hanging outside the.
Okay.
The rest of the wire is feeding through the device, through the springs between the device and the top cap. Okay.
Okay.
Outside the device. Okay. So you essentially forget about the human body, forget about the patient. Okay. Now what you have a situation where about 5 centimeters outside the fenestration. Okay.
Yeah.
Forming a U as it goes inside the device.
Yeah.
Coming out through the springs in the between the top cap and the device.
Yeah.
And the rest of the wire is now being coiled outside. Okay.
It's been coiled outside. Okay.
Now forget about the patient for a moment. So
Okay.
effectively, the part of the wire that is inside the device is just between the fenestration and the springs of between. Understood?
Okay.
Yeah, it's a U that is forming. Okay.
It's a U. Yeah.
Now you've got a catheter that is going in from the right brachial.
Yeah.
Okay. Coming out through the left groin.
Yeah.
Okay. Now the excess wire that is being coiled up.
Yeah.
Okay. Now first you resheath this device.
Okay.
Okay. Which was unsheathed. Now you resheath it. Now everything is, now that excess bit that was hanging outside the 5 centimeters is between the sheath and the crimped device now.
Okay.
Now on top of this resheath, imagine, look at the diagram. You are putting it back in now. Crimping it onto this.
Yeah.
The device is resheathed again.
समझ में नहीं आ रहा है.
Are you looking at the diagram on the WhatsApp group?
No, sir. I will see.
How will you understand? No, you have to take a look at the reference image. Open the EVL continuum. I would request everyone to open up the EVL continuum WhatsApp group. I've put in a diagram.
EVL.
Are you seeing it?
Just a minute, sir. EVL 2020 or I could not get.
No, it's on the group. Has everybody else received?
Vascular study group में है ये क्या किसमें है sir?
Continuum 2020. Are you on that group?
I think I am not there.
मैं डालता हूँ सर, आपके स्टडी ग्रुप पे डालता हूँ, आप उस पे देखो.
हाँ जी सर. EVL 2020 ऑर्गेनाइजिंग टीम में हूँ
मैं डाल रहा हूँ सर, एक सेकंड.
ओके सर. ओके.
डल गया सर, डल गया.
ओके.
डल गया सर. अब देखो एक डायग्राम है.
हाँ जी डायग्राम है.
हाँ बस उसी को देखना है सर, उसी पे ही समझा रहे हैं
सर.
अब
एक बारी सर, सॉरी सर डॉक्टर सात्विक, एक बार दोबारा से समझा.
So now think this is going on the bench. Okay. The diagram I have made is a diagram on the bench. Forget about the patient for the moment. Okay?
So the tip, Satwik sir, you can hear sir?
I can hear.
So the tip is taken out from from the fenestration around 5 centimeter. You have made a U.
Yes.
And the back end is taken out. It is above. This is on the bench right now.
On the bench, it is coiled up. It's an exchange length wire which is coiled up.
Coiled up. Okay.
The tip is come out forming a U. Okay.
Yeah.
This is when you've unsheathed the device on the bench. Okay.
Yeah.
You've created a fenestration.
Yeah.
You've featured the edges of the fenestration with the wire. Okay.
Yeah.
Once that is done, you take in the tip of the wire.
Okay?
That is the floppy end. I mean the front end.
The tip. Yeah.
About 5 odd centimeters hanging out, or you can have a little more than that if you want. Doesn't matter.
Yeah.
The rest of the wire is going first going inside the device, then coming out of these struts, the springs between the top cap and the device, and is coiled up.
Yeah. Okay.
Is that clear till this point?
Yes, so you have coiled it. You have coiled it up
and kept it on the table.
Okay.
Now you refeed the device.
Yeah.
Okay. So what happens?
Yeah.
That 5 centimeters of floppy tip.
Yeah.
Stays between the sheath and the crimp device.
Yeah.
Understood? The rest of
and
the
it is wrapped with the umbilical tape also. No.
It is wrapped. I mean, that's the part
Okay.
of the resheathing process, right? I mean, as
Yeah.
you.
So it's wrapped in the umbilical tape, and it is between the sheath and the crimped graft.
Umbilical tape is basically just to crimp the device. That's all.
Yeah. Yeah. Yeah.
You tie it and then you release it, unclamp
Yeah.
it, untie
Yeah.
it. That is just to
Okay.
crimp the device.
Okay.
The umbilical tape is just to crimp the device. That is all. Okay.
Yeah.
So now when you resheath the device,
Yeah.
you will find that this excess 5 centimeter tip is between the sheath
and the stent.
and
Yeah.
the device, the stent graft.
Yeah. Yeah.
The rest of the wire is passing first within the device, coming out through the struts.
Yeah.
Between the top cap and the device, and then lying coiled out on the table. Okay.
Okay. Okay.
At this point, now
Yeah.
what happened is you have a catheter in place from the right brachial.
Yeah.
That is coming out through the left groin.
Left groin. Yeah. You have snared that, or you have taken that into the sheath, and then you have end coming from right side and one end coming out from left side.
Left groin, right brachial. The catheter has been introduced. 125 centimeter catheter introduced from the right brachial, coming out through the. Okay, understood.
Right.
Coiled end, the back end of the wire that is lying on the table.
Yeah.
You feed it in a way so that it goes through the catheter coming out of the left groin.
Okay.
And keeps coming out through the body out of the right brachial.
Okay.
Got it?
Okay.
Yeah, got it.
And then, so you basically have a system now that is connected. This wire is now part of
to the right brachial. Yeah.
Part of it is between the sheath and the device.
Yeah.
As it's going through the fenestration, and the other end is out of the right brachial. Understood till this point?
Yeah. Okay.
Just 1 second. I'm getting a call. I'll just 1 second.
Sure.
Okay?
Sure.
Yeah, Tapish. Sorry.
Yes, sir. So, I mean, you make sure that you're not pulling the wire, otherwise it will come out whatever you have crimped between, or, I mean, does it hold there?
My resident is just calling. Yeah, sorry. So, so now we've got a connection. The wire is coming out through the right brachial, and you're right. You don't have to pull on the wire because otherwise it will come out through the fenestration, right?
Yeah.
So now you take the device up through the left groin, take it to its.
That is first you have to place the wire, any Lunderquist or anything.
Yeah, of course. So this, remember, the space for the wire in the device has not been affected.
Okay.
This is going through between the struts, remember, of the top cap.
Okay.
It is not the designated space for the
so
wire.
So the lumen is still left, the designated space. You take the Lunderquist and you have I mean, this is going sheathless, right?
This is sheathless. This is a Medtronic device. Yeah.
Okay. Yeah.
So this is an arteriotomy, a cut down in the left groin. Okay.
Okay.
So you've now taken a Lunderquist and convey the device up into its designated position. Okay. Now open the top cap.
Yeah.
Some people try, as in this case, I think the fenestration was cannulated without opening the top cap. But you should open the top cap. It just creates more space for your catheter and sheet to come in. So now open the top cap. Your catheter can be advanced on the wire, and once you take the catheter, it will automatically come out of the fenestration because the catheter
and get aligned with the right renal.
Yeah. So it's outside the fenestration. You don't need to cannulate the fenestration because managed to find the fenestration automatically because your wire was already out of the fenestration.
Maximum, how many wires can the device accommodate? 2 or 3 wires if we have one wire right now.
So it's not a problem with the device. That is not the problem. The problem is with your sheath. How many sheaths, how many catheters will you put in through the brachial? Otherwise, you'll have to do an axillary cut down.
Okay.
No, because a 6 French sheath is not going to allow, or a 7 French sheath, brachial, you can't upgrade it anymore, right? I mean, you can't put in French or so it's not going to allow more than 1 catheters to come in.
Okay.
Right? So that in that case, you might require an axillary cut down if you wish to have more hardware going in from above.
Okay.
I hope it's clear to all participants what I was talking about and what was done in this case.
Yeah, it is clear.
So now we have the left renal catheter out of the fenestration but into the sac, and we are trying to cannulate the left renal.
Yes, sir. Yes, sir.
Satwik, sir. Hello.
Satwik was.
Hello.
Hello. Satwik, sir.
I can hear you. Go on. Sorry. Yeah.
Yeah, sir. Hemant here from Jiva, sir. Sir, is there any way to do the same thing, pre-wiring, for the femoral approach, sir?
For the femoral approach?
Means whatever we are introducing through
He's
the
saying not
approach.
Getting through the brachial, but getting it down.
No, but
that's what he's asking.
We'll have to come out from somewhere, right? Where will you do this? You're taking the device up from one side, the other one will have to come out from somewhere, right?
So basically, Hemant, the thing is that what Dr. Satwik has said, that this comes from the struts from above because you have not unsheathed the whole device. You have come to till the flow divider only. So till the time that you unsheath the complete device, you cannot take the wire down from the struts below. So this is, you just open 5 centimeter till the flow divider, make your fenestration and take the wire out from above. If you have to take it down from below, then you need to unsheath the complete device.
No, also, I think it makes sense only to take it between the struts, because in this case, we don't even have to come down to the flow divider, because, the flow divider is fairly low. As you can see, where it is. The fenestrations are way above the flow divider. So you just need to unsheath enough to make your fenestrations, which have been measured based on the CT. But you're right. I mean, this only works if you've got an access from above, that's the point of pre-wiring.
Yes, sir. Yes. Thank you, sir.
Yeah. So I'm not getting any audio feed from the cath lab. Ganesh, can you look into it?
Yeah. Apnea.
So, sir, can you let us know what is being planned? We can't see where the left renal is.
Sorry, sir.
We don't seem to see where the left renal is. I mean,
Yes.
Sir. Yes, sir. Madhu sir, trying to convert the left side of left. Right now, where is the point?
So, sir, can you hear me, Dr. Bedi sir? Ajay?
Hi.
Hi, okay, this is Ambarish.
Hi,
Just
Amrish.
so we can't seem to see where the left renal is. Have you localized it? Because
We have an idea. We're getting a very, very rough idea of where it is, but we're still not sure because the problem is it's at such an odd angle.
Yeah.
No amount of catheter manipulation.
Right. So what the plan will be come from above to the chin.
Blood.
Hello, Ganesh. Ganesh. Hi, Ganesh.
Hello. Hello.
Hello, Ganesh.
Sir, but I can hear you.
Acha, Satwik, you can hear?
I can hear you.
Now, what is the progress regarding the left renal artery?
So, we are trying to localize.
Satwik, can you hear me?
Yeah, I can hear you. Can you hear me?
Yes, I can hear you. What is the progress regarding the left renal?
They managed to come out of the fenestration, but the exact location of the left renal is not very clear. So they're trying to change the angles and trying to find the left renal.
Okay.
Once they find that, they'll cannulate it and then they'll put in a stent. They're out of the fenestration, but not able to perfectly localize the left renal.
Okay. Ganesh, can you hear me? Ganesh? Dr. Ganesh, Dr. Nikhil?
Yes, sir. Yes, sir.
Can you
Sandeep,
hear?
sir. Ganesh here.
There is no voice from that side. That's why I'm asking
Yes, sir.
what is the further plan?
Further plan, actually, we are closing the groin, sir, now.
Okay.
Closing the arteriotomy.
Okay. We have done the brachial percutaneous puncture only, no? We have not exposed it, no?
Yes, yes, sir.
Okay.
Bilateral brachial percutaneous puncture and left open up.
Okay. Achha, so now we are closing the groin.
Yes, sir.
Okay, okay. So have we removed all this wires and everything?
Yes, sir. Everything we have removed, sir. All long sheets and everything has been removed.
14 millimeters from the SMA, whereas the left renal was just about 8 millimeters away.
Yeah.
So let us see how the kidney behaves and all. But the urine output so far is good. The patient is hemodynamically stable. But
That
there
is very
always
important.
some
That is very important.
loss of branch happens from the sheaths. So that is what the thing is.
Will we do some CT angio tomorrow?
The left renal was not arising from the aneurysm. Kamal, we have seen the axial cuts and all the left renal is arising from the aneurysm only. And that's just taking off at 1 o'clock position and then it goes up and then goes downwards. So it's a very funny kind of an angle. So it has to come a little anterior because so it has to come anterior at 1 o'clock position, and then after that it takes the left turn. So it's a little tricky thing because of angulation and all, and that's what we have seen in different angles. We have been able to see the renal artery from LAO as well as RAO, but then the only thing is we have seen the first angio, Kamal. In the first angio, we were seeing the renal artery. The left renal artery was well seen, and maybe we can show you that initial run that we took. Because
it was
one relies a lot on the
very tough case. Very
axial
tough.
cuts of the CT angio. So in this one probably it is getting overlapped. Next one. Yeah. Okay, नीचे देखो, ऊपर देखो ना, SMA के नीचे थोड़ा go back, back, till you see the SMA. So when you look at this particular run out here, here you have the SMA. थोड़ा सा front जाना, आगे जाना. Yeah. So if you look at the SMA, there is a vessel which is crossing across the SMA, which is probably the left renal. I'll just use the cursor and show you. Here we have the SMA coming down, and this is one branch which is coming down and exactly at the same distance, which is going across into the renals. So most likely this is the branch that we are looking at, but unfortunately it is at such a funny angle that after that subsequent runs we were not able to see this renal artery again after that. And we were only able to see that once we entered the fenestration and that took some selective shoots out here. Then we were able to see the renal artery. And you can see in both the LAO as well as the RAO that the artery is moving absolutely, coming anteriorly and then going horizontally across. So literally you have to come anteriorly at 1 o'clock position and then after that get your wire across into the thing, and then the whole sac is there at the same time. So we entered through the fenestration, but we were not able to get across. We used different catheters, then we used a micro catheter also, but then we decided that discretion is better part of valor, and we will try to come back another day and try to conquer this.
Sir, will we check this patient tomorrow by a CT angio?
Sorry?
Will we check this patient tomorrow by a CT angio? What is happening of the left renal artery?
Hello?
Hello?
Hello? Yes, sir? You're saying something?
Ganesh?
Yes, sir.
Will we do some CT angio tomorrow for this patient?
CT angio tomorrow?
Yeah. Hey, Abhi, sir told na that we will see what is happening at the fenestration which we made for the left renal artery.
So we will have to see on angio how the whole graft modulates according to the aorta. Sometimes it gets stuck nicely to the wall and then you need not do anything. But we will do a CT angio at the end of 1 week, and then we will take a call. If there's an endo leak, then probably we will go in and fix that. Either by cannulating the left renal also, or if we are not able to do that, we'll put in a plug.
Okay, sir.
Right? Yeah. So I think we will leave it at this. And if anyone is interested in watching a case of varicose vein, that will be taken up after about, I think, around 3 o'clock. Yeah.
Okay, sir.
Thank you.
Thank you, sir. Thank you.
Bye-bye. Bye. Bye.
Thank you everyone for joining. So again, we have next case of varicose veins. We'll be doing a RF ablation in that one. So in that case, we'll intimate you. If any further questions are there, otherwise I will. Thank you, Nikhil. Thank you, Hemant.